We have added, we tried to keep as consistent as we could with some of the same members that we had last year, just so that, you know, we're not starting all anew and having to re-explain everything. So a lot of our ad hoc members were with us last year. And we do have, in addition this year, we've added the judicial branch to our committee. So we're very excited with that. So I think now we have literally covered all of our bases. So that part's very, very exciting. And for those of you that are new, it's kind of a little bit of a different format in that what we're going to do today is we're going to kind of go back and look at what this committee did last fall, what our committee report said, what we got to check off on the checklist that was on the back of our report, which we think was very exciting. And then we will break out into 3 work groups. So as we proceed today, you might be kind of thinking is what work group would you like to be on? Keeping in mind, legislators, the work groups are not mandatory for you because you do not get paid for those. I just highly recommend that if you want to be active, that you do participate, but it is a choice that you all get to make yourselves. Those are done virtually, and I believe, Carrie, you can nod at me, you're going to do 90-minute work group meetings. So they'll all be virtual, 90 minutes, which is kind of nice because you don't have to do all the traveling and everything and you get it done. So you're not tying up a whole day, and that's why we don't pay the legislators. We've been authorized for 6 days for this meeting. You will see on the schedule that there's 7 because I kind of break the rules a little bit. My goal is to do it in 5, and that's the 5 meetings. Today counts as one of our meetings. So I think that that is doable with the fact that we've already got the groundwork laid and we know that where we're proceeding from here. So if we'd like to, we could go around and introduce our members that we have with us. And I think, Megan, we'll start with you and come around, and any of our ad hoc members that are with us today in the room. And then we'll go to those that are virtual.
Thank you, Madam Chair. I'm Representative Megan Lynn from the 49th District in Olathe.
Thank you, Madam Chair. Renee Erickson, Senate District 30, Wichita.
Thank you, Madam Chair. Representative Adam Smith. I represent the 120th District out in extreme northwest Kansas.
We like Western Kansas, just so you know that.
Good morning, everyone. Carolyn McGinn, Senate District 31.
And I didn't introduce myself. I am Brenda Landwehr, 105th District from Wichita.
Thank you, Madam Chair. My name is Mike Hagg. I represent District 14 Senate.
Yes, even you, Will. We want you to introduce. There's a mic in front of you. Yes.
Good morning, everyone. Will Carpenter, District 75, northern portions of Butler County.
And that's an honorary person you got sitting next to you, just so you know that.
Thank you, Madam Chair. We share some things in common. And I guess I'm an ad hoc in a different kind of way. Senator Tom Hawk from District 22, Manhattan. Great to be here.
That was bad, I'm just saying.
Get worse.
Representative.
I'm Representative Linda Featherston. I represent the 16th District, which is Overland Park, and a little bit of Lenexa.
Thank you, Madam Chair. Good morning, everybody. My name is Tori Marie Arnberger Blue, long name now. I represent Great Bend and Hoisington in Central Kansas.
Good morning. Thank you, Madam Chair. Rob Winnell, District Court Judge, Johnson County, 10th Judicial District. Pleasure to be here. Thank you.
Do we have any of other ad hoc members that are with us here in the room? Seeing none, virtually, who do we have online?
Jane Adams, Keys for Networking.
Good morning, Sandra Berg with United Healthcare.
Good morning, Claudia Duck Tucker, Senior Vice President of Government Affairs and Public Policy with Doc Health.
Denise Sisman from Community Care Network.
Morning, Brenda Sutter with DCF. I'm the Deputy Director of Medicaid and Mental Health.
Good morning.
Christina Morris with CVS Health.
Will Warren, Sunflower Health Plan, TLC, and Olathe.
Good morning, Sarah Fertig, State Medicaid Director, KDHE.
Jean Clifford, State Board of Education, District 5.
Josh Mosier, Kansas Health Information Network.
Deb Stidham, Kansas Association of Addiction Professionals.
Greg Hennon, 4 County Mental Health Center.
Lisa Southern, Compass Behavioral Health in Southwest Kansas.
Wes Cole, chairing the Governor's Mental Health Services Planning Council.
Winnie McKinney, Advent Health Behavioral Health.
Spence with Official Administration.
Rachel Marsh with the Children's Alliance of Kansas.
Good morning. I'm Charles Bartlett. I'm the Director of Adult Services at Behavioral Health Services. Also serve as the liaison for the Governor's Behavioral Health Council.
Good morning. I'm Jeff Easter with the Sedgwick County Sheriff's Office, also with the Kansas Sheriff's Association Legislative Chair.
Laura Brake, Director of Crisis Services with KDAD's Behavioral Health Services.
I'm Sally Pokorny. I'm a district court judge in Douglas County, and I preside over a behavioral health court.
Gary Hinault, Director of Youth Services, KDADS.
Is that pretty much everyone?
Don Jordan, former Secretary, Department of Social Rehabilitation Services.
I wondered if you were out there, Don. I was checking on you.
Okay.
Yeah,
I'm Wes
here.
Cole. I'm Wes Cole. I chair the Governor's Behavioral Health Services Planning Council. How do I get on there?
I think we've got everyone, don't we? At least those that are able to attend today. So a lot of familiar faces, and I'm glad to see that. And I'm also happy to see some of the new faces that we have joining us as well. So we're going to go ahead and start. What? Oh, Senator Alley, are you there? All right, we can come back to him in a little bit. All right, we're going to go ahead and we're going to start off with Connor Stangler for an overview of the 2020 Special Committee on Kansas Mental Health Modernization and Reform. So, welcome.
Thank you, Madam Chair, members of the committee. Can you hear me okay?
Yes.
Okay, thank you. I am here for a couple of purposes. First, I am here to review a memo, and then I will review a couple of spreadsheets that you should have in your packet, and for others that were out on the table out there outside the room. And again, I should say I'm Connor Stangler from KLRD. The first document I am going to review is an overview of the 2020 Special Committee on Mental Health Modernization and Reform. It is on this, I think technically goldenrod is this color, sunflower paper.
Just kind of a rule.
I'm pretty sure I got it wrong, so. The 2020 Special Committee on Mental Health Modernization and Reform was directed by the Legislative Coordinating Council to analyze the state's behavioral health system to ensure that both inpatient and outpatient services are accessible in communities, review the capacity of current behavioral workforce, study the availability and capacity of crisis centers and substance abuse facilities, assess the impact of recent changes to state policies on the treatment of individuals with behavioral health needs, and finally, make recommendations on steps needed to make Kansas a nationwide leader on behavioral health delivery, specifically focusing on how Kansas should modernize its behavioral health delivery system. The Kansas Health Institute agreed to facilitate working groups for the 2020 Special Committee. The 2020 committee determined working groups consisting of roundtable members and ad hoc subject matter experts would help the committee's charge. The 2020 committee began with 3 voluntary working groups. Legislative members could volunteer to participate in the working groups meetings as consultants. There were 3 working groups to begin with in 2020. First, the Finance and Sustainability Working Group focused on monetary and human resources and related topics, including workforce, funding and accessibility, and community engagement. Second, the Policy Treatment Working Group focused on how to make the mental health system more effective, with particular emphasis on prevention, education, treatment, recovery, and special populations. Third, the System Capacity and Transformation Working Group considered what the mental health system could look like in the future and focused on data systems, interactions with the legal system, and law enforcement, and system transformation. The committee later created a telehealth subgroup featuring members from each working group, which met twice during November 2020. The other 3 original working groups met 7 times each. The working groups used KLRD's Crosswalk of recommendations to review and assess past recommendations. You will see on the memo the committees from which this 2020 Special Committee drew for its own recommendations for the Crosswalk. Working groups also proposed and crafted their own new recommendations. Each working group divided recommendations into those that required immediate action, which were those recommendations the working group believed could be completed in the next 2 years, as well as those recommendations that were of strategic importance, which referred to recommendations that could be addressed over the long term. The final working group recommendations were categorized by 10 topics listed there on your memo, the topics listed there. They are also listed on the 2020 recommendation checklist spreadsheet, which I will get to in a brief second. The 2020 Special Committee produced a final report and submitted it to the legislature and relevant committees in January 2021. That report is available on this committee's resource page on the KLRD website. I will stop there for any questions the committee might have on this overview of the 2020 Special Committee.
Committees in the room or virtual, does anyone have questions with what he's covered this morning? I just wanted, I think those of you, it was kind of a refresher for those of us that were on this committee last year, and then for the new members, just kind of give you an outline of what it is that you've volunteered to get into. So are there any questions? Senator Hawk.
Thank you, Madam Chair. Could you define what the term crosswalk means? I'm assuming it's just looking at other groups' reports, but.
Yes, of course. Madam Chair, the crosswalk was a structure, a spreadsheet that KLRD produced for the committee last year. You will find a new one here on this spreadsheet right here that you should have on your packet, which I'll describe in a second. But it was an overview, a survey of recommendations that were relevant to mental and behavioral health topics proposed by other committees, task forces, subcommittees that we have listed there.
So the term is created by KLRD. It's not a mental health or behavioral health term.
That is my understanding. It's just a general term for this kind of document.
I just didn't want to miss that in my lexicon in case it was something I didn't get in my master's training. Thank you.
No, it was kind of a new term and just a working one that you hear a lot when you're with the working groups. Senator Erickson.
Thank you, Madam Chair. Thank you, Connor. The document references that the working groups divided their recommendations into prioritizing those that needed immediate action and so forth. Is that somewhere in our packet, or is that in the report online? Do we have access to those priorities?
Yes, thank you, Senator.
Thank you,
Madam
Madam
Chair, yes, those importance levels, sort of that hierarchy, is in the larger report of the 2020 Special Committee. That can be found on the KLRD website, for example. We have a special tab for 2020 interim committees. And if you pull up that report, it does have that entire thing enumerated. I did not include it on here just for brevity's sake, and just to make sure we know what the main topics were.
We kind of encourage, Senator, for people to review that online because there's a lot of hyperlinks that are, hyperlinks that are connected to that report, because what we've done is any committee, task force, et cetera, in the past that had been involved in mental health, we've brought those all in. So when you look at this report and you hear us talk about, say, the governor's behavioral health, there'll be links to take you to what those reports were in the past. So you don't have to go searching for them, because we felt like it was important for us to look at the whole picture of mental health, not just what this committee had before them. Further questions? All right, seeing none. Thank you very much, Connor.
Sure, and I have a couple other documents to review very quickly for the committee. The second document is a recommendation status checklist. This is separate from the crosswalk. I'm going to try and distinguish these two oversized spreadsheets you have here. The one with the yellow bar at the top that says 2020 Special Committee on Kansas Mental Health Modernization and Reform status of recommendations is the one I'll be talking about right now. What this is a list of the recommendations from last year's special committee. Next to each recommendation, you will find a status that's on the far left-hand side, either in progress or completed, as well as responses from primarily agencies, either the lead agency listed on that recommendation by the 2020 Special Committee, and or responses from key collaborators, also primarily agencies. KLRD, for the 2021 Special Committee, solicited responses from agencies named on this spreadsheet for a status update on any recommendation for which they were listed as either the lead agency or a key collaborator. As you will see, there are sometimes more than one listed for each category. So perhaps more than one lead agency, more than one key collaborator. Additionally, we have updated any legislative activity from the 2021 session where the legislature was listed as the lead agency or key collaborator. Are there any questions on this status spreadsheet? And I should mention, we are going to go through this with representatives from the agencies that submitted responses. So we will go through this pretty comprehensively here in a few minutes.
Committee, are there questions? Seeing none, proceed.
The third document that I will review is the updated KLRD crosswalk. That is the other large spreadsheet that you have with multiple colors at the top. This is the September 2021 KLRD crosswalk. This is very similar in structure to the 2020 crosswalk. Last year, the committee and its working groups worked with a crosswalk of recommendations from various committees, task forces, and council that had issued relevant mental health recommendations. The working groups used those recommendations in their development of their own recommendations. For this year, KLRD pulled recommendations germane to behavioral and mental health from a similar collection of committees, and you will see them listed there. The 2020 Kansas Criminal Justice Reform Commission, the Governor's Behavioral Health Services Planning Council subcommittees, and you will see that there are some subcommittees listed under that column as you go through the spreadsheet. The Governor's Commission on Racial Equity and Justice December 2020 initial report, the 2020 Special Committee on Foster Care Oversight, and the 2020 Bob Bethel Committee on Home and Community-Based Services and Can Care Oversight. KLRD grouped relevant recommendations into the topics of the special committee used last year for its recommendations. So you'll see they are the same 10 topics from last year as you go through the spreadsheet. And I should also take a moment to mention another document in your packet that will prove, we hope, useful. That is our glossary of acronyms. There are many acronyms as I'm sure you're familiar with, in these documents, on the crosswalk, on the status of recommendations. We tried to be comprehensive. If there is an acronym or initialization you see that is not spelled out in the glossary, please let KLRD know and we'll take care of it.
This is always very useful. My first year in representing Ballards in 1997, yes, we're aging ourselves, that was one of the first things we asked for. We needed a dictionary for the acronym, so we appreciate this.
Yes. And finally, I wanted to mention the KLRD resource page. This is online on the KLRD website. There you will find, if you navigate to the KLRD website, there's a big committees tab at the top of the page, and that takes you to all the 2021 interim committees. If you click on our committee, Kansas Mental Health Modernization and Reform 2021, there is another tab at the top that says Resources. There you will find the report from the 2020 Special Committee, the entire report on mental health modernization reform, the 2020 recommendation status checklist that you have in front of you, a KLRD memo on behavioral health related legislation passed during the 2021 session, which actually you have as a paper copy in your packet as well. It's the purple lavender one. The memo on the special committee that I talked about at the beginning, historical funding charts that Mr. Matt Moore from KLRD will be presenting in 1 second, as well as the text and the summary of legislation for Senate substitute for HB 2208, which enacted the Rural Emergency Hospital Act, established certification for CCBHCs, authorized out-of-state physicians with telemedicine waivers to practice telemedicine in Kansas, and modified licensure and regulatory requirements on the BSRB and its licenses. And we also, last thing I'll mention, we have a green memo which spells out essentially a summary of each committee that we drew for the recommendations for the current crosswalk. So that's on your green piece of paper. That simply summarizes the structure and logistics of each committee, council, and task force we used for the current crosswalk of recommendations. And with that, Madam Chair, I am finished with my presentation unless you have other questions.
Committee, are there any questions for Connor? All right. Oh, Senator Erickson.
Thank you, Madam Chair. Connor, on the multicolor banded spreadsheet here, just an observation. It seems interesting to me that the only topic that has no relevant recommendations from any of those other groups is community engagement as it relates to workforce. I mean, in every other context that we're hearing, workforce is such a huge issue. It's a little surprising to me that none of those other groups are tapped in to that area, or am I not understanding the purpose of that scope of this spreadsheet? So can you kind of help me understand that?
Sure. Senator, Madam Chair, for the workforce recommendations, we tried to mostly group them under topic 1 if they were really anything related to workforce. The community engagement, which I think is defined in last year's 2020 report, had more to do with public engagement through information sharing, publications of pamphlets and things like that. But if there were workforce recommendations that we identified, we put them under the first topic. I think when we go through the recommendations, the last year's recommendations, I think some of the agencies could speak to those topics if there's the community engagement one they wanted to point out. But there was some overlap with that first topic. And if we identified that, we put that under that first topic related to workforce.
Okay, thank you. That's very helpful. Thank you, Madam Chair.
Committee, further questions? All right, seeing none.
Thank you.
So now we're looking for Matthew Moore, our fiscal analyst. Welcome to committee.
Thank you, Madam Chair, members of the committee. My name is Matthew Moore. I'm the fiscal analyst who covers the budgets of KDADs and the state hospitals. Today, I'll be providing just a brief overview over my mental health funding chart that we produce every year. It is your only ledger-sized document. As it is so large, it is the only size paper that it can be printed on. So You've probably seen this before. We've kind of shifted things a little bit to make it a little bit more readable, so you'll see the notes are on the side. It starts off kind of the first giant block of funding is with community mental health centers. So the first few lines are kind of divided into the various sorts of grants that they receive from KDADS. And then you see that subtotal line there at the bottom of what CMHCs would receive from KDADS. The next, you'll see that there are a few lines that end in 13 that are primarily Medicaid related prior to CanCare. And then you'll see a non-categorized Medicaid mental health payments. So those are after CanCare started. Any sort of amount for Medicaid that goes towards mental health, that's going to be the portion that when we do caseloads every year that are going towards mental health for individuals on CanCare. The next kind of block are mental health grants that are not CMHC specific. So those are going to be various federal grants, some ones that are funded with special revenue funds. The first one being funds that are generally for fighting homelessness, again, with individuals with mental health issues. And then there's another group of various grants that have either ended or are kind of continuing that are very specific. The next one would be Clubhouse Model. Those are going to be funded primarily through the lottery vending machines, and you can see that sort of increase since, I think, 18. The next two are community crisis centers and Rainbow Services. So those both together are the kind of all the funding for community crisis centers that here in Kansas. There are, I think, currently 5. There's Rainbow, which gets its own line because of it's the larger of all of them. But then there's Vallejo here in Topeka. There's Salina and ComCare. And then I am blanking on one. I know there's one more.
Is it Johnson County or?
No, I might be thinking, I know that there's Douglas County is starting up, as well as I think there's one in Leavenworth. So it's, I thought I said I think.
You said ComCare. That's all right. You can get them to us.
It's footnote 6. So it's ComCare, Vallejo, and then Salina are the ones that are currently in place with the addition to Rainbow. And then I know there's Douglas County is starting to get in place. And then I think there's one maybe in Leavenworth in the works too. So the one thing that I'd like to note is that, again, we do separate Rainbow out because it is the larger appropriation, but ComCare, Vallejo, and Salina all have direct SGF appropriations. And then all of the other ones kind of share an amount from the lottery vending machine revenue, which for 21 last year that they received $4.2 million total going directly to that fund.
Matthew, isn't the Rainbows one of the reasons that it's financed different? It's structured a little bit different, I think, than any of our others, correct?
Yes, I think that's why it's kind of the first. It's structured a little bit differently. It was kind of the first to receive that direct appropriation, so it is treated a little bit differently, and so that's why we've broken it out. And then the other ones we kind of lumped together since they are more alike and do receive that that revenue from the lottery machine all kind of together.
Well, and I believe that in the 2 mental health reports that Kay and I did, I'm going to get my years wrong. Is Carrie still in the room? Carrie, was that 17, 18?
I'm sorry, what?
The two mental health reports that Kay and I did.
KHI,
KHI, excuse me, not K and I.
Actually, the mental health task force,
yes,
which was KDADS convened. They met in sorry, my apologies. The K and I threw me off there for a second.
Well,
but
I'd like to say it's Monday, but that's not my excuse.
No worries. They convened in 18 and 19 for reports that came out in 19 and 20. They were dated because the reports came out in January.
Okay. The reason I bring that up, committee, is that They're extensive reports, but if you felt like you need some reading material, it's actually kind of nice to go back and see the history of how some of the different mental health programs we have were created and how they're funded and why they're funded the way they are. I found that, even though I've worked on that, like I said, back since 1997, I found it interesting just to, kind of be refreshed on why we did what we did and why we're doing it, because they're not all created equal. And at first glance, you think, okay, well, this doesn't make any sense. But then when you get in and find out why we did it, it does make sense. So that would just be a reference if you felt like going back to getting that. And those are also online as well. Proceed.
And so the final on that mental health grant is the statewide mobile response that started in 22. That's slightly related to the 988 number. That's a kind of a pool of money for individuals that call the 988 number, need a little additional support, and that was added last year in the governor's recommendation and made it through the legislature. So those are all those lines for the mental health grants. The next line would be residential treatment. So those are going to be psychiatric residential treatment facilities and then nursing facilities for mental health. Then I have a special line there for the funding that was added by the 21 legislature. Mainly, there's the funding for the Emperor Hope pilot program for 22. That was an item that was originally approved by the 2020 legislature, but was allotted and subsequently added back for 22 last session. There's the funding for the CCBHCs. I will note that that funding does include both a kind of administrative function for KDADs to establish the CCBHCs, as well as the start of services for I believe it's 4 that they're going to begin implementation starting off. And then that final amount is the operational funding for the 988 number that was added for $3 million. The next line would be the funding for the state mental hospitals. So that's going to be Osawatomie and Larned, as well as a little bit for Rainbow Mental Health Facility back when it was in operations. And those are just going to be the operational costs for those facilities. They don't include any capital improvements. Then there's a few state hospital expenditures for KDADs, a little bit of these food service expenditures in 14 through 16, but the main one would be the state hospital diversion regional beds. And I think now they're referred to as state institution alternative beds. These are beds that are outside of the state hospitals that individuals are screened to either go to a bed in the community or go to the state hospitals. One thing I would like to know is that does include the Hayes acute care beds. That's where you would find that funding in that 21 and 22 amount.
Matthew, we don't have those beds online yet, do we?
Not yet. My understanding is that they're still working out the contract and it's in the procurement process. And I am keeping my eye on that to get word whenever they do. And then finally, just a few mental health funding in other agencies. There's a few with the Department of Corrections, some with KDHE, and then some with the Department of Education. And unless there are questions, that's...
Representative Arnberger. Well, I'm going to get back to the blue eventually, so.
I don't know what my name is half the time, so that's fine. Thank you, Madam Chair. A couple questions. The 988, that was just added into the budget bill, if I can remember correctly, but the bill that we worked on in committee, I don't think we passed it out of committee. Is that going to have to change, that bill, because this was started and added in this year?
So, Madam Chair, so my understanding is that, yes, that bill did not make it out. It was, I believe, to provide I think it was maybe 50 cents for the telecarriers to fund the 988 number. Since that bill hadn't made it out, this funding was added, a direct SGF appropriation, I think with the understanding that that would be the funding to begin with while the bill is being worked out.
Okay, thank you. That was my first question.
Representative Arbor, the $3 million is just for the startup for the call centers, because that's critical, because this goes on online July 16th of next year.
Okay.
So the other funding needs to come forth. We ran up against a block with the telecom saying no, no way, and H no. And then we also had some legislators saying no and H no. So Kansas has to decide if they want to be a major participant and do what's right for mental health next year with the 988 funding.
Okay, that was my first question. And my second one is just maybe more of a request from Department of Research. If you guys could send me the extensive budget to Larned State Hospital, that would be great. I'd like to do a little bit more of a deep dive into that. Just looking at funding, how it went up and then now it's back down. Granted, it is much higher than 2010, but that's kind of close to my backyard. So I just would like to dig a little bit more into that. Thank you.
All right, Representative Carpenter.
Thank you, Madam Chair. Matt, I'm just looking through this, and I'm kind of going on my memory from last year, which could be an error here. The charts that I had last year on this funding were about $576 million. What is the $100 million difference in this chart here? I do notice that Medicaid mental health payments are down quite a bit. Can you elaborate on that?
I'd have to double check to see what last year's chart was and how it dropped. I mean, I do know, particularly with the state hospitals, there were some allotments. It certainly wouldn't be that, drop that amount, but I can certainly compare the two and find out for you.
Okay, thank you.
Senator Hawk.
Thank you, Madam Chair. A couple of quick questions. On your mental health grants on community crisis centers, I'm looking at your notes on 5 and 6, where it says the lottery vending is $6 million, and then the direct allocation for ComCare, et cetera, is $1.8 million, but the total is $6.3 million. Why is there a $500 million difference? Or are we not anticipating that we're going to get the full $6 million from the lottery?
So the statute is up to $6 million, and so it's been steadily increasing year after year. So the amount that's included in the chart is what the anticipation for what we would receive that year. And the governor's recommendation at the time, which is what the approved number was, $3 million. And like I said, the funding that came in for fiscal year 21 ended at 4.2. So they can receive up to $6 million, but it's slowly, steadily been increasing since that was implemented.
And what happens if people get tight and don't buy, don't go to those vending machines, and we don't get adequate funds for the other crisis centers? Do we make a special general fund allocation, and does it come out of this line?
I think I could probably answer that and not put him on the spot. What we've done in the past, Senator, is because the machines were delayed, I believe, and Representative Ballard can help me with this because we were cohorts in this little thing, is a couple of years it took them to get the vending machines up online, so we supplanted SGF in there to take care of that. So I would see in the future that probably, legislatures would have to decide whether they supplant the SGF if it runs short or not fund it.
Well, let me thank the two of you for that, because I think those are excellent community-based treatment options. I have one last question, Madam Chair.
That's fine.
And I don't think we can answer it yet, but I know there was an AG allocation in the budget for, I think, social media suicide prevention that relates to the 988, and I'm not sure about and I think it was a substantial amount of money. So my question for us as we progress is, it seems that these two efforts should be closely coordinated, and I wonder how that might be happening. And I was thinking we were going to be online sooner than July of 2022, but so we have some time. But I just have a question about how having some of that, I think, is this at KDAD's where the 988 number is?
And I don't know if, I think I saw him poke his head in here a minute ago, but I don't know if Andy Brown's online, or is he out in the hallway?
I don't need to have that answered now. I just.
Well, I think he'll have a quick answer for it.
Okay.
So we might as well, because I think you bring up a good point, because if I recall correctly, and Andy will correct me if I'm wrong, I don't believe those two are tied together.
Yeah,
You would
and
think they were, but I don't believe that they are.
And I may question whether they should be or not, and I would
That's
think
fine.
they should be.
That's fine.
But how to do that, I have no idea.
Do we have other questions while we're waiting to round up Andy? Anyone online with a question? Oh, Senator Alley? Is he maybe on mute or something? Do we know? Senator, you're on mute. Okay, maybe someone needs to give him a call and let him know that we've got problems. Andy, I'm going to have, because I don't believe we've got the speakers on out there, so if we've got folks out there, we can turn them on for you, which I'm going to do right now, is if you'll rephrase your question, Senator, for Andy, I think he'll be able to answer that for you.
Well, you're asking me to make a behavioral health leap that I don't often do well in remembering.
Hey, we all leap into this sooner or later.
Yeah, please clarify my question if I don't remember it the way I asked it. No, we have the 988 number that I think is at KDAD's, and then we also have, would you like me to continue or wait for Senator Alley? Oh, okay. So back to my mental health suicide question. So there's was an allocation to the AG's office for the suicide prevention. I think it was for more of the social media website type. So my question is, how is that going to coordinate with the 988 number, and how are the agencies going to cooperate in seeing that we have a comprehensive program?
Yeah, so Andy Brown, I'm the Commissioner for Behavioral Health Services at KDADS, and Senator, we have a interagency council around youth suicide prevention that involves the AG's office, KDADS, KDHE, and Board of Education, I think, or Department of Education. And so those agencies meet on a quarterly basis and discuss what suicide prevention programming they're doing around youth and try to coordinate those efforts, right? So one thing that the AG's office is working on, I believe, is a mobile app, like a mobile phone app. And I believe the intention is for that to be able to direct people to 988, both for chat and text messages, as well as possibly helping their phone dial the number. Does that answer your question?
Yes, and I'll sort of keep a question mark in the back of my mind about is that's great to have interagency cooperation, but there's no line of structure to see that happens, if I hear you right. Well, other than the agency doing it, but no requirement that those two mesh together. Hopefully it will happen.
Yeah, I do believe that there's probably not a statutory requirement that the agencies work together. The AG's office does have statutory stuff around their youth suicide prevention coordinator, and that's currently Gina Meyer-Hummel. And so she has some duties and expectations that are laid out in statute.
Thank you for that information. Thank you, Madam Chair.
Committee, further questions? Senator Alley, are you with us now? Okay, well, when we get this figured out, we'll have you join us. Representative Carpenter.
Thank you, Madam Chair. Looking at the difference in these sheets, it may have something to do with the increased FMAP from 2020 and 2021, but what I'm seeing here is that the Medicaid, the MCO portion is down about $100 million over the last 2 years. So did we compute that differently? I'm just curious.
What I will say in thinking about that, so it shouldn't necessarily be a FMAP issue because the chart should be all funds, so it should include all federal funding. What I will say is, I mean, the chart that you had is the what was approved last year or for the 2020 session. And at that time, caseloads might have been projected higher for a population-wise, just because maybe at that time we weren't quite sure where we were going to be at. I know that to get the temporary FMAP, there is a requirement that we can't remove people from Medicaid. So for a while, some of the caseloads are a little bit higher, just anticipating a higher population that would be eligible for those services. And so these figures would have been the most current from the last time we would have estimated caseloads, which would have been a little further into the pandemic, had maybe a better grasp on what that population might look like. So that might be one explanation for why there's such a dramatic decrease, because in the chart that you had, it would have been kind of right at the beginning of the pandemic, when we weren't maybe quite sure what the population would look like that would be eligible for Medicaid.
Well, I see that, but I'd appreciate you looking into that, because if you look back historically, it changes all these numbers from one sheet to the next mainly on that Medicaid line. So I'm just wondering if there was a different way of calculating that or what, but it's remarkably different. So last year that it was the same was 2016. So anyway, thank you.
Committee, further questions?
Madam
Senator
Chair.
Alley? Someone else have a question?
Yes, hi, Kelsey Torres, Behavioral Health Consultant at KDHE. I had a clarifying question. I wanted to know, does this history of funding chart just look at SGF allocations, or does it also include federally funded programs?
It should include all federally funded programs. For instance, I know some of the mental health grants in the middle are federally funded and special revenue. The state hospitals do receive, both SGF and federal funds. So in all, it should encompass, to the best of our abilities, all of the federal money as well that would be out there for mental health.
Thank you. I think some of the KDHE federally funded grants may not be included on here, but I'll double check those things and follow up with you.
Thank you. Further questions? All right. Thank you very much. Appreciate this. All right, committee, the next thing we have on our agenda is a presentation of the Governor's Behavioral Health Services Planning Council. And these are draft subcommittee reports, and these are written only. So if you go down your list with the service members, veterans and their families, children's subcommittee, evidence-based practice subcommittee, subcommittee on housing and homelessness, justice-involved youth and adults, Kansas Citizens Committee on Alcohol and Other Drug Abuse, Prevention Subcommittee, Problem Gambling Subcommittee, and the Rural and Frontier Subcommittees. Those are all in your folders, or for those of you that are online, that should have been sent to you. So those are written only. So again, nice reading material for you later on. Next, now we're going to have a presentation of audit report on evaluating mental health and substance abuse initiatives to improve outcomes, which was supposed to be Heidi, but we're actually going to have Kristen with us this morning. And I'm not going to butcher your last name, so I'm going to let you tell me how to pronounce it.
Sure. My name is Kristen Rottinghouse.
All right. Welcome to committee.
Thank you, Madam Chair, members of the committee. I'm glad to be here today. As mentioned, my colleague Heidi Zimmerman was supposed to bless you with her presence. She was the supervisor on this audit, so I will do my best to answer questions that you have and promise that anything I can't answer, I'll take back. We'll connect and try to get back with you all on that. So if you're following along, you should have, with a hard copy at least, it'd be a copy of our audit report that includes our logo on the top, so legislative post-audit. I would also point out for anyone who has access to like a electronic device, if you do check out our website, so all of our reports are available electronically as well. And I point that out in this instance because a couple of the figures I'm going to talk about, figures 2 and 3, are interactive. So you're not going to see anything in the printed report, but you would be able to see that in the electronic version if you have access. So with that in mind, I'll jump into the report. And so in this instance, we were asked to answer 2 questions. The first question is, what practices or programs do state-funded mental health and substance abuse providers report using, and how well do they appear to be working? So the short answer is that Kansas providers reported using many evidence-based programs and practices. So I'll take you through what some of those are. But data limitations kept us from assessing how well they are working in Kansas. So I'm gonna, if you're following along, I'm on page 2. I'm gonna skip through a lot of the background because I know you all have quite a bit of knowledge here. Just a couple of important points maybe to clarify the work that we did. So the question is about state-funded programs. So we looked at 4 agencies that capture the major programs. Those are listed in the bullets on page 2. So we looked at the KDHE, Department of Health and Environment, and Medicaid, KDADS for the mental health and substance abuse block grants. Also, of course, they oversee the state hospitals, community mental health centers, that sort of thing. The Kansas Sentencing Commission, which oversees the Senate Bill 123 stuff, and then the Department of Corrections. So those are the major state agencies. Obviously, then the programs are provided by a network of private, public, and nonprofit providers, including things like the state mental health hospitals, community mental health centers, and private practitioners. So those are the folks we reached out to learn what practices and programs they were providing. So if you're following along and you turn to page 4, that's where I'm at. So we talked to 23 providers about what type of programs and practices they used. So we selected the 23 as a judgmental selection. We tried to do that in a way to get a good cross-section of all providers in terms of location and size. If you want more information on who we talked to, we did list those individuals in Appendix A. So the 23 providers that we talked to reported 95 different practices and programs that they use to treat mental health disorders and substance use disorders. None of those are required by state law or regulation, but some do have licensing requirements that require them to provide certain practices. So I'm actually going to direct you to, I'm going to jump a little bit here, but to page 6, and you'll see figure 1. So I just mentioned that we heard from providers about 95 different programs and practices. That is a lot. So we chose 11 of the most commonly reported practices to look at in more detail. So those 11 are what you're seeing in figure 1. So out in the far right-hand column, you'll see how many providers reported using each practice or program. And then on the left side of the figure, you're going to see what I'm going to talk about in just a minute, but that is how effective those treatment programs are according to national and international literature. So the fewer dots, the less effective. The more shaded dots, the more effective. So again, those are the 11 that were listed. We did consult, this is kind of starting broad, just looking at the literature. What does it have to say about whether or not these practices are effective? As you'll see in that figure, 8 of the 11 had moderate to strong evidence supporting their effectiveness as a treatment. So one of those, which is listed at the top, cognitive behavioral therapy, had the strongest support for its effectiveness. 7 of them had moderate support, and by moderate, that's kind of our LPA's term, meaning that some literature supported its effectiveness, some didn't. So, for example, some were found to be effective for certain conditions, but not others. So, an example, eye movement desensitization and reprocessing is an effective treatment for post-traumatic stress disorder, PTSD, but more research is needed to determine its effectiveness for other disorders. It could also be the case that the treatment found positive effects for some outcomes, but not others. So we grouped those sorts of things in the moderate category. And then for 3 of those 11 practices that we reviewed, research was either weak or was inconclusive. So that's for the 3 you see at the bottom of Figure 1, peer support, integrated dual diagnosis, and the strengths-based model. So if you're still following along, if you'll flip to page 7, that's where I'm at now. So again, we kind of started broad, looking at the literature. Then what we were going to do was look at outcomes data specific to Kansas so that we could speak to whether or not those treatment programs suggest that there are good outcomes, again, in Kansas. We couldn't do that because there's not good comprehensive data on outcomes in Kansas. And even, I'll get into this a little bit more, even with good data, there are some difficulties, just what's the best way to measure, to capture some of these outcomes. So issues I know you all will be grappling with. So just a couple of examples, which I'm in the bullets on page 7, there at the bottom. Determining what a successful outcome is can vary based on the person and their condition. So for someone with a substance use disorder, getting and keeping a job may be a signal of success, like a good outcome to track. However, for someone with schizophrenia, fewer psychiatric hospital admissions may be the appropriate outcome measure. Just a couple of examples. Another difficulty with kind of capturing this information is, of course, that a lot of these individuals with mental health or substance abuse needs it tends to be a transient population, which makes that, of course, harder to track and to collect data. So in addition to that, of course, the 4 state agencies I just mentioned, we did reach out to them to see what type of data, outcomes data they maintain. So none of the 4 have data that is complete and reliable. So in some instances, this is top of page 8. A couple of agencies simply don't collect outcomes data, like the Sentencing Commission. KDHE collects some outcomes data, but not for those who receive mental health or substance abuse services that are paid for by Medicaid. Again, KDADS collects some information is specific to the mental health and substance use block grants, but that information is incomplete. We did some kind of reliability work and found that we didn't think it was reliable enough for us to report out on that information that was available. So we also tried to reach out to those providers. I mentioned the 23 that we talked to. That's hit or miss. So some providers do track outcomes, others don't. There is no requirement for those people to sort of report any consistent outcomes to some centralized place, which all of that boils down to. We didn't have the data available to be able to say whether or not those 11 practices and programs are effective in Kansas. So with that moves me to question 2. Again, this is still page 8. And that question had us look at how do Kansas's practices compare to those in other states. So here we used 2019 data from the Substance Abuse and Mental Health Services Administration, SAMHSA, to compare Kansas to 5 other states. We looked at Idaho, Iowa, Nebraska, Nevada, and South Dakota. We chose those because they are similar to Kansas in terms of population, median household income, and the percent of population that reported illicit drug use. So here's where I'm going to mention those couple of figures where if you're following me along in the printed report, you're simply going to see a link to our website. But we did look, it's maybe the easiest way for us to be able to show. So we compared in figures 2 and 3 what practices and programs Kansas has to those 5 other states. And then on the left-hand side, if you click on that, those bars will change to show how Kansas stacks up. So figure 2 is looking at how Kansas substance abuse providers compared to the 5 other states on 18 metrics that we thought were relevant that SAMHSA collects. That our takeaway is Kansas is pretty similar when it comes to those practices and programs. So for example, like cognitive behavioral therapy, 98% of the reporters to SAMHSA from Kansas reported using cognitive behavioral therapy, and those 5 other states anywhere from 91 to 98% of providers reported using cognitive behavioral therapy as well. There are a couple of maybe exceptions to that. So Kansas had fewer substance abuse providers that offer hospital inpatient services, and had fewer providers that offered therapies such as dialectical behavioral therapy, contingency management, and community reinforcement. And then figure 3 is looking at, instead of substance use, it's looking at mental health providers compared to those 5 other states against 19 metrics that SAMHSA collects. Again, overall, pretty similar. There are some exceptions. Kansas had fewer mental health providers that offered trauma counseling and dialectical behavioral therapy, but more mental health providers that offered services like telemedicine, suicide prevention, and emergency psychiatric services. So again, we wanted to be able to compare Kansas outcomes to those other states specific to Kansas, but for the things we just talked about, the reasons we just talked about, we weren't able to compare Kansas to those other states in terms of outcomes. So we did not have any recommendations as part of this audit. If you're interested, we do have a response from Secretary Howard with KDADS on page 10. I guess that technically came from Andrew Brown. My apologies. And with that, that's my presentation. I'm happy to answer any questions.
Any questions? Representative Arnberger.
Thank you. Thank you, Madam Chair. I have 2 questions. One on figure 1, when you are comparing the number of providers and then the strength of evidence for the 11 different practices, is there a reason why not all 23 provide that service, such as, is it because maybe in the rural areas it's difficult to get the specialty employees, that kind of stuff, or funding, or did you guys come to a conclusion on that?
We didn't ask that way. We kind of we started with going to the 23 and saying, what do you provide? We didn't actually start with a list of here's some practices and programs and then reach out and say, why do you do this or not do this? So I unfortunately can't answer that question.
Okay. And then the second question I have is when you guys were going through with the second question on this audit and looking at figures 2 and 3, was there a state that's the maybe a model state for mental health or for substance abuse? Was there a state that just stuck out that they're just doing such a great job?
No. Okay. I would say, so some of the things that I think are struggles here in Kansas are maybe similar to some of those others. So for instance, these types of things tend to be pretty decentralized, I think, across, again, we just looked at 5, but those 5 states. So trying to get a good sense of overall, how are they doing? We didn't see any of them that just had great, this is a place we can go that has outcomes data that's available, that kind of stuck out in that way.
Okay, thank you.
Committee, further questions? Senator McGinn and then Senator Erickson.
Thank you, Madam Chair. I'm looking at your website and that chart, and I'm trying to understand quickly what are the measuring, determining factors of the other states? Is that in this full report? How do they measure? You said we couldn't measure with them because we don't. What things do they measure, and are they similar or different?
So we didn't collect their state-specific outcomes, like going to their KDAD's equivalent to see what the outcomes are, we simply looked at the SAMHSA data that's available. So that's those figures 2 and 3 are looking at data that those states report. So Kansas does report to those too, but it's simply saying of the providers, how many reported using or providing that treatment program or practice. So that's what those percentages are showing in those figures.
I think I know what you're saying. It's just, I guess it'd be nice to have, I think what I need to do is look at the SAMHSA area to understand how they are reporting it. Correct?
I think it's through a survey. I don't know if this is what you're wondering, but SAMHSA does a survey where they simply reach out and ask people to report what practices and programs they provide. So that's what you're seeing in those figures. When I say outcomes data, I don't know if this helps, things like decreased recidivism, that type of information isn't something that is, to our knowledge, that's collected or readily available from one of those other states we're kind of easily grab and compare, again, because we don't have that information for Kansas either.
Thank you.
Senator Erickson, then Representative Lynn.
Thank you, Madam Chair, and thank you for this report. It's very helpful. My question is, what is the effectiveness of Figure 1 based on if there's a prevalent lack of reliable outcomes data that sounds like it's across, all states? So how do we know those practices are effective if we don't have the outcome data?
Mm-hmm.
Thank you, Madam Chair.
Good question. So those, we referred to like academic literature, so it's not specific necessarily to, like some of them might be specific to a state, but it could be more of like a study someone did where they looked at a particular provider and did a study on those individuals to look at those outcomes and decide whether or not they're effective. But nothing so there's nothing statewide for Kansas that's in there. But what you're seeing in Figure 1, I don't know if I'm doing a good job or I'm making this more confusing, but Figure 1 is simply speaking to those pieces of literature and what they had to say about effectiveness. Some of those are international studies as well, so from other countries looking at the effectiveness of the programs they studied. And we list some of those if you're interested in checking them out. Appendix B does list some of the literature that we looked into.
Perfect. Thank you, Madam Chair.
Representative Lynn.
Thank you, Madam Chair. I think this kind of goes along with what Senator Erickson just asked, but have you looked at just one provider who provides comprehensive services to see what kind of success rate they have or the measurable data they have on a more micro scale, not statewide?
We did not as part of this.
I'm guessing we have some providers who do have a comprehensive array of services that potentially we could look at their success rate.
It's possible that there could be like some of those providers. It was, again, hit or miss. Often the larger providers or maybe have more resources and have done more in that area to look at outcomes.
I'd be interested in seeing what kind of outcomes they have. So thank you. Thank you, Madam Chair.
Well, and I think representative is, we have to keep in mind when legislative post-audit, they're given us a scope, and that's the scope that they go after. And then that audit itself then may raise new questions and different questions. So I think, some of what you and Senator Erickson are asking are probably very valid questions to be brought up in the working groups. We sometimes forget because, we get into a search mode and realize they're just bringing us the data back that we had originally asked them to do. So are there any further questions? Do we have anyone that's online with a question? I'm not seeing it. Oh, Representative Featherstone, is that right? Featherstone.
Featherstone, it's okay.
What? Pronounce it again.
Featherstone.
Okay, I'm going to get that.
Okay, thanks. Do you know, is it standard practice in the mental health field for individual providers to track their success rates from client to client?
I don't think that that is something that is required, but there may be other people who are better,
Okay, thank you.
better suited to answer that.
Any further questions? All right, seeing none, thank you very much. We appreciate the presentation, and I hope that she's got that Heidi has a quick illness bug that she can get over quickly, so
I
thank you
appreciate
very
that.
much.
Thank you.
All right, next committee we have on our agenda, if you're following along there, is we'll have presentations on the status of the 2020 special committee, which is in our recommendations that we mentioned earlier. And Andrew Brown, you're up first if you want to come in from the hallway. Andrew? Oh. Oh, okay. Welcome back to committee. Now, do we have written comments from everybody on this, in this group here? Oh, is it in the cage? Okay. On the spreadsheet. Oh, right. Yes, we like visuals. Thank you very much. Welcome back to committee, Andrew.
Thank you, Madam Chair. And so what we're planning on doing, if it works for the committee, it's just having each agency sort of report out on the ones that they're the lead for. Is that correct? We're just reporting out on the ones we're the lead for, correct? So for KDADS, and this is Andy Brown, I'm the Commissioner for Behavioral Health Services at KDADS. But for KDADS, we start on the second page with 1.3, which is the provider MAT training. And we've been working on this. The status that we're reporting is in progress. Primarily what we're running into with MAT training is that we're continuing to put policies and procedures into place and working with KDHE and KDOC on those issues. The easy implementation on this was like a 5. We feel like we're making good progress for the first year, and we hope to continue to make advances on that. One of the things that we've added recently is we're going to be adding alcohol MAT to our uninsured population folks through the block grant. For 1.4, we also reported out that this is in progress. Right now, KDADS is planning on using ARPA funding for workforce investments in the short term. And then we're also planning on doing a more long-term study as recommended.
And the ARPA funding is the COVID federal dollars right now.
Correct.
So for those of you that don't know what that is. So that's one-time money.
So then on page 3, recommendation 1.5, we are reporting that that is currently in progress. We've issued a family engagement RFP for fiscal year 22, but unfortunately we weren't able to get any bidders that were within our price range. So we've been revisiting that. We issued a grant and we applied for a federal assistance of care grant. We were not awarded those federal funds, but we're continuing to work on this to identify additional funding to support that RFP. Then for page 4, we have recommendation 2.2, which is addressing inpatient capacity. You may be familiar or have heard us talk about SIAs in other committee meetings, but our state institutional alternatives, or SIAs, are essentially our regional model that's supposed to help us support lifting the moratorium at Osawatomie and also providing some relief on the western side of the state. Those facilities and that plan also include construction for additional beds at Osawatomie. in the Biddle building. And I'm going to defer any questions to Scott, who's here today also, but he can come in and maybe help address those questions around the hospital. So then for page 5, recommendation 2.4 for suicide prevention. KDADS did submit a budget enhancement and supported legislation that would have provided funding for suicide prevention infrastructure for fiscal year 22. However, neither that enhancement nor the bill were approved and passed. So we did not have adequate funding to work on this recommendation this year. Despite that, KDADS has reallocated some existing resources in order to create a position within BHS that will be a full-time state suicide prevention coordinator. And additionally, through continued joint efforts with our sister agencies, KDADS has successfully completed the launch of the Kansas Suicide Prevention Coalition earlier this month. That coalition will work on making recommendations to the agencies as well as to the legislature about infrastructure needs here in the state. And then additionally,
Andy, I'm going to ask a question here on that. So is any of this tied to our 988 funding?
Yes.
So this is all the 988 funding piece?
Yes.
Okay, thank you.
And then additionally, the council completed and posted the new 5-year state suicide prevention plan. And we continue to have a focus on our service members, veterans, and families. And we launched a Governor's Challenge Extension project in Manhattan this summer. And we're working on expanding our goals and objectives to the Flint Hills region around Manhattan.
Representative Ballard has a question.
Sure.
Thank you, Madam Chair. When you say that the Governor's Challenge Extension Program, would you explain that? I'm not really familiar. I know a little bit, but what did you expand?
Yeah, so under Governor Collier, we started the Governor's Challenge Program, which is focused on preventing suicide among service members, veterans, and families. And we work with the SMVF TA Center, SAMHSA, the Veterans Administration, as well as our local VA hospitals on suicide prevention issues. So we developed a plan, an action plan that we're doing statewide. And then the Governor's Challenge Extension is essentially a project that supports those efforts at a local level. Does that make sense?
Yes, it does. May I follow up, Madam Chair? Now, are we talking active duty servicemen? Are we also including veterans in that? Because that's where the rate is so high.
Yeah, it includes active duty service members. It includes our National Guard. It includes our Army reservists. It includes veterans and their family members. So if you're the wife or spouse of a service member, if you're a son or a daughter of a service member.
And one more, Madam Clerk. And are you working with the Veterans Administration whose job is to also do this, and they have, 11 field operations out there in order to contact the veterans? Are they included in this?
Yeah, this is a federal initiative. Kansas was one of the first states to participate in it. But it's a federal initiative with the Veterans Administration and SAMHSA. And those two federal organizations are working together to fund the projects.
Thank you very much. Thank you, Madam Chair.
Representative Armberger Blue.
Thank you, Madam Chair. Just a real quick question, Andy. Where it says ease of implementation score, could you explain the ranking? I know it's 1 through 10. Is 10 the high? How did you guys decide all that? Thank you.
Yeah, so on ease of implementation, 10 is easy and 1 is hard.
Go ahead.
All right, so on page 6, recommendation 3.1, crisis intervention centers. We marked this one as in progress. KDAS continues to work with the CMHCs to expand crisis services. We were able to use increased funding and revenue from the lottery vending machine fund in order to add additional crisis stabilization units in new areas of the state. And we also are close to completing the Crisis Intervention Center regulations, which will then allow us to license new facilities such as the ones in Douglas County as crisis intervention centers. And then we are also looking at seeing which crisis stabilization service providers are interested in becoming CICs as well.
Questions? Proceed.
Okay, so the next one is on the same page, 3.2, it's the IPS community engagement. So KDADS has included IPS, which is individual placement supports. It's a supported employment evidence-based program. We have included that in our NFMH pre-litigation settlement practice improvements. And so we'll be working to accomplish that by spreading the quality assurance and fidelity review for IPS and building that into our CCBHC system.
Do you have a fiscal on that, Andy?
I do not have a fiscal on that at this time.
Okay, thank you.
I do believe it would be included in the fiscal estimate for the CCBHCs. On page 7, we're just supporting collaboration there. So moving on to page 8, recommendation 3.4, the community-based liaison. We marked this one as in progress. KDADS has included jail liaisons in the CMHC participating agreements for this fiscal year and is working with KDOC on reentry issues through TA opportunities supported by the Council of State Governments. The Stepping Up TA Center is operational with block grant funding, and both the Center and KDADS have been involved in helping with the Chief Justice planning the Behavioral Health Summit to further support local communities. This is one area where additional state funding would be beneficial.
Questions, committee? Okay, proceed.
All right. And then 4.1, we also marked this as in progress. This is the 988 Suicide Prevention Lifeline funding. We currently have a bill that's in committee in the House around 988 funding. And we did receive $3 million in the state budget last year to support preparations for implementation of 988. So we would continue to seek passage of that bill. And we did award grants. So that $3 million that we were given, we did award grants to ComCare in Sedgwick County, Johnson County Community Mental Health Center in Johnson County, and to Kansas Suicide Prevention Headquarters. Those are our 3 current NSPL crisis centers. So we're working with them to help get them ready for 988, which starts in July. And so that funding was distributed based on the population that they served.
And the national is based out of Lawrence and is the current headquarters for the 800. And then it feeds over, is that right?
Yeah, so the way the system works is the SAMHSA has a contract with Vibrant Behavioral Health in New York, and they administer the National Suicide Prevention Lifeline. And then here in Kansas, we have 3 National Suicide Prevention Lifeline crisis centers. One of those is in Wichita at ComCare, one's in Johnson County at Johnson County Community Mental Health Center, and then the third one is Kansas Suicide Prevention Headquarters. And that provides statewide coverage. And we also, we needed to RFP our crisis and triage contract this year. And so we added a requirement that that provider, whoever receives that, would also work to become a National Suicide Prevention Lifeline Center. So we should, by this time next year, have 4 National Suicide Prevention Crisis Centers, and I'm working right now with SAMHSA and Vibrant to see if we can set up our own backup center here in Kansas so that we have a chance to, a second chance to answer all those calls before they leave the state.
So do you think that the fourth one might be a little more rural?
No. Unfortunately, it's based here in Topeka, but they do work with the rural CMHCs and answer a lot of calls for them already. So I think that there will be some, there'll be some benefit there.
Okay, because I mean, and I know we've got some committee members on here that come from rural areas, and even those of us that don't, we have family members out there, and that's kind of a big need. Yeah, big need, as Representative Ballard just said.
Yeah, and we do have, you know, for those CMHCs in those areas that do provide their own phone answering services, and for the hotline under the participating agreement, we can look at having them apply to be an NSPL crisis center. It's about a 6 to 7 month process to get accredited with the NSPL. And I think that that's certainly possible for smaller centers to do it. And we did have, you know, 2 of our CMHCs that have completed that. It's just they've been in urban areas so far.
Okay. Representative Featherston, did you have a question? Okay. And I'm going to ask you if you could move a little to your right. No, then I can see you when you have a question. So.
Okay.
You can, and because just because we put your nameplate somewhere doesn't mean you have to get stuck there. So thank you very much. Okay, proceed. Oh, Senator Hott.
Thank you, Madam Chair.
You have to send me up smoke signals. I have a block here too. So
I'll do that. I always like to be in a block position, though. You mentioned there's no federal funding for 988. Why is that? And is it possible we could use ARPA money to do some of the expansion that you're talking about?
Well, so it's a two-parter, right? So
I'm sitting here going, no. But go ahead.
Yeah. So the first answer is that there's been no federally designated funding for 988, right? And that's, you know, that's partly because the way Congress passed their bill, they sort of passed that cost on to the states and said, you know, we're going to create this, and if you want to have it funded in your state, you need to pass legislation to do that. And then, and I think there is some current effort in Congress to try and see if they can amend that language to create funding, but so far that hasn't happened yet.
But they did provide language that gives the states the ability to assess a new fee to all phones, similar to our 911. And like you heard earlier, the 50 cents was creating quite an angst with a lot of individuals, which I found very interesting because in 2019, we added a 41 cent like that for 911 strictly for infrastructure. And the fee that would go on for this 988 is not so much infrastructure as it is actual services, because I believe we're required, am I right, on the mobile crisis units that have to be established. And it does, when we talk about a mobile crisis unit, we don't mean a bricks and mortars where we have it staffed 24/7. It means it's more like a volunteer fire department. So these individuals are working in this arena for us, but if they get a call to move the mobile crisis unit, they go. Because a lot of people thought we were doing bricks and mortar, and it's not. You know, we wouldn't even be able to staff something like that because of the shortage that, I don't care what area of healthcare, I'm not close enough to my mic, what area of healthcare you're in, the shortage is real. And we're obviously very short in this area here, but the mobile crisis units are vitally important. And some of our communities have already kind of instituted a little bit of that to where they have, from my area, and I know there's several others, that if the dispatcher, the 911 dispatcher knows that it's possibly someone that is dealing with a mental health issue, then law enforcement moves with some mental health professionals because our law enforcement are not social workers. They're not trained for doing that. And some people have asked, well, why don't we train them to do that? Well, I think that their training is focused on serve and protect, not in the area of mental health. And Andy, anytime that I misquote that, because I'm trying to bring back from the cobwebs that we spent a lot of hours on, so tell me I'm wrong.
Well, I think you got the gist of it. And then Senator Hawk, for part two, do you want to refresh my memory about what part two is?
That's just me always looking at ARPA funding or the old CARES funding.
Yeah, so at KDADS, what we have looked at is we're going through that process with Spark around the ARPA dollars to see if we can get funding for behavioral health as part of that. And so if we're successful in receiving some of those funds, then we would be able to do that. But so far, KDADS has not directly received ARPA funding that is set aside for 988.
Well, and I think I would be, have some reservations that being ARPA is one-time money, that wherever it gets spent, that it's on one-time issues versus ongoing services that we need to provide. So that's why you heard me earlier, I was like, no. Because that's always a big concern with one-time money.
Yeah.
And also, I believe that one of the things that's different with this ARPA money than the money that we had several years ago is that there is no supplanting of SGF.
Right. Yeah. So we're, any other 988 questions? I guess I should check before I move on.
I'm not seeing any online,
Okay.
so.
So then for 4.2, this is early intervention specific to early childhood mental health. So KDADS is continuing to, we mark this as in progress, and KDADS is continuing to research the fiscal impact of this as the recommendation involves changes to the Medicaid system. We do have to look pretty carefully at what our budget neutrality is on that particular issue. So we are looking to see if it's possible for us to make that part of Can't Care 3.0, which is coming up. And we're also trying to figure out if we have the room and the budget neutrality for us to implement it or not.
And I might add that the budget neutrality issue has become a bigger issue than it's ever been in the past because the feds have changed how that works. And we had a major discussion of that this year through the approach process because I was operating on yesterday's information and then all of a sudden we're like, no, this is why it's a big issue. So, and I know Representative Carpenter and Representative Ballard are very familiar with that.
So then on page 9, recommendation 4.3 is the centralized authority. And I'm going to report out sort of on behalf of the governor's office today. But Secretary Howard is designated as the centralized authority, and the governor's office's position is just that this would be completed. And then for the next one, it's 4.4. That's the behavioral health prevention. This is to increase state funding for behavioral health prevention efforts. KDADS did support legislation to this effect last session, and that legislation still remains in committee. We were successful in applying for additional federal grant funds to support prescription misuse, but has not received any additional state funding at this time. We did reallocate agency funding to fill the state suicide prevention coordinator position, like I mentioned earlier, but we have not allocated any additional funds for drug and alcohol prevention. All right, so for 5.1, also on page 9, this is for PRTFs. So KDADS continues to monitor progress on PRTF waitlist weekly. Currently, Kansas has more licensed PRTF beds that are unstaffed due to workforce issues than it has children on the wait list. $1 million was added to the KDAD's budget to support the pilot of the NRI study recommendations at Ember Hope. Ember Hope has completed its licensing requirements and its grant award is being finalized. And they're beginning to serve children next month in October. So we feel like that's good progress on those particular issues. And then for 5.2, that is the service array. KDADS has explored options. We did not expand MAT in the block grant services. Oh, sorry, we did expand MAT in the block grant services. So we feel like this one has been completed. And we feel pretty good about the policies and practices that have been put in place both at KDADS and with KDHE. And then for page 10, 5.4, which is housing, KDADS was successful in receiving a requested budget enhancement to expand the supported housing and also to hire a Housing First project coordinator position. So those funds were granted and have been awarded to the Douglas County area as seed money to launch their Housing First team. And we're continuing to look at how ARPA funds can be used to further expand supported housing in Kansas, and that'll be a significant part of our ARPA requests. Kansas is also now one of the leading states in the SOAR program. We made the top 10 list this year. And we continue to look at how we can expand SOAR services to SED youth, including the creation of a position in BHS to support that effort. So again, we feel like that's pretty good progress on housing. For page 11, recommendation 6.2 is parent peer support. KDADS is close to completing this recommendation. We did have some Systems of Care grant funding that ran out before we could complete the training project. So we're working to identify additional funding sources to complete that. And we're also working on a state plan amendment with KDHE that will provide Medicaid funding to support that service. So right now, funding is really sort of the main barrier for 6.2. And then for 6.4, which is the IDD waiver expansion, again, if there's any questions about this one, I'd defer those to Commissioner Penrod. But the implementation, we feel like this is in progress. The major concern, again, is how do we secure the funding necessary for 4,500 additional waiver participants? We are using the 10% FMAP bump, and there was some talk about that last week in Bethel. But we are using that to do a study of the wait list and the individuals that are on it to help determine what services they need based on their individual situation. And we're hoping that that will help us prioritize and better address those issues for people that are on the wait list. And then on page 12, 6.5.
Andy, just one moment here, and I'm sorry, because I was trying to monitor it. I got people talking to me on text. Was that the 6.3?
6.3 is crossover youth, and I think DCF is planning to address that.
All right, so 6.4 was what, okay, that's what I thought, but I wanted to make sure.
Yeah, and then 6.4 was the IDD waiver expansion.
Right. And one of the things that we're doing in that piece there is part of the 988 suicide prevention legislation is to add crisis mobile units for our IDD, not just for our MH population.
Okay, so for page 12, Recommendation 6.5, these are the family treatment centers. Again, we marked status for in progress. KDADS is supportive of this recommendation, and we're continuing to license and designate facilities as they are opened. But we have not yet sought any additional funding to incentivize providers to open these types of facilities. So as a result, we haven't had any that were open in the last year. But we do think that it's a good recommendation, and we will continue to try and find ways that we can support it. 7.1, we also marked this one as in progress. Currently, we are in the procurement process with an RFP for this EHR project. We feel good about the progress we've made on that so far and expect that we'll be able to award a contract on that later this year. For page 13, recommendation 7.4 is a needs assessment. This needs assessment is to identify gaps in funding and assess SUD treatment providers. So we've been exploring what resources are going to be needed in order to conduct a statewide needs assessment specific to these SUD services. And at this time, we have not yet made a funding request for this recommendation. And then for 7.5, this is around cross-agency data and developing policies and MOUs to support that. KDADS is working on this with our key collaborators on TA projects with federal TA providers that include data sharing policies, MOU development around a variety of subject areas, including like SUD, for example. We also are working, just as an example, with Board of Pharmacy on the prescription drug monitoring program and sharing data from that to help us with our CAN-CARE reporting responsibilities under the 1115 waiver. Okay. And then on page 14, 8.1 is correctional employees. This is about expanding training. So KDADS and KDOC worked on a TA project this past year and made some changes to how inmates are screened for SUD upon intake. This helps with earlier identification and puts the inmate on a path for treatment and recovery upon release. KDADS is also continuing to provide crisis intervention training and law enforcement officer training on behavioral health. So this is an ongoing effort to expand training, and more expansion is still needed. And then on page 15, this is 8.4, defining the crossover youth population. I feel like KDOC and DCF have done a good job addressing this, but I did want to just acknowledge that we're one of the lead agencies, and we've been participating with the crossover youth work groups.
Representative Ballard has a question, Andy.
Yeah.
Thank you. When you said that, I'm looking at crossover youth, a young person aged 10 or older with a level of concurrent involvement. How many students or how many young people do we actually have enroll in this?
You mean like what's the number of crossover youth that have been identified? I'd have to get back to you on that. KDOC may be able to answer that when they're reporting out.
Do you think that's I see, oh, is that a large number and who's responsible for it, I guess, is what my question might be.
Yeah, well, and it's interesting because I feel like we're all sort of responsible, right? Like there's definitely aspects that behavioral health needs to address with the percentage of kids that are crossover youth and have a behavioral health diagnosis. And out of that subpopulation, that's a really high number of those kids, right, that have some sort of severe emotional disturbance or disorder. Our overall numbers as a percentage of the Kansas population are relatively small. I mean, these are high-need kids that are, you know, not the median of what kids' expectations or behaviors are in Kansas, right? These are exceptional kids that are what I would oftentimes terms like a complex case, right? They have needs that aren't easily met by the system.
Well, Madam Chair, Mayor, that's why I'm asking, because I see it's like you have Department of Corrections, and we have KDADS, we have DCF, and like you say, the question is, yes, everyone's responsible for it, but when everyone is responsible for it, but no one takes the lead on it, then they get lost somewhere in the middle of all of that. That's why I was really asking. And because the age 10 or older is, the 10 is the 10, the 14-year-old is that difficult age that's there, and I'm just making sure maybe in a way that someone is actually watching out for that population, because older gets more attention, but younger, some kind of way, gets lost a little bit.
Yeah, well, and this work group is really focused on even earlier ages than that, looking at how we can prevent people from becoming separated from their families, from becoming involved in the justice system. That's a lot of what our diversion programs are about, our family preservation programs, right? But crossover youth are those that have already sort of slipped past that prevention effort and are now engaged with the justice system.
Okay, that helps. Thank you very much. Thank you, Madam Chair.
All right. Representative Carpenter, did you have a comment or question?
Thank you, Madam Chair. Just a very quick question. I see TA in here. I'm not sure that is acronym that I'm used to, technological assisted. What is that?
So, yeah, so technical assistance, what that really looks like is having support for the state staff from subject matter experts at the national level. So we work with Council of State Governments. We work with SAMHSA designated TA centers around different prevention, around prevention, treatment, addictions, and cultural competency. And there's a couple other TA centers that are out there that provide specific services around suicide prevention specifically, or problem gambling, right? And those types of TA providers, we're usually able to get those services through federal funding, either direct funding to the state to apply for the TA assistance, or through an application process to the TA provider.
So this is our staff using technology, or is this the?
Well, it's technical assistance. So it's not technology. It's just technical assistance.
Oh, okay.
Right. So it's helping us understand how to do better policy work, helping us understand how to do better community engagement, those kinds of things.
I get it. I was thinking like in the TA waiver world. I thought I need to explain how that works.
Yeah, same acronym, different meanings, right? Yeah.
Okay, proceed.
Okay, so I think I'm ready for page 16, which is recommendation 9.1, the regional model. So again, this is where we've worked to develop the state institutional alternatives. And we launched that program just recently. And so we're still working out some of the kinks in the system, but we're bringing on new hospitals and expanding that group of providers and looking for ways that we can set those up in other areas. And then we're also exploring opportunities to look at how we might be able to use properties and other things that have been pointed out to us.
Andy, I was thinking the other day in the King Care oversight that, and maybe I'm confusing it with one of our other programs, but that we had perhaps one of these out in the Hayes area?
We will, right? So right now, we have funding that we received through the legislature last year to open up a youth hospital for psychiatric services, and that facility will be a state institute alternative.
So when you list Wichita, Newton, and Arc City, those are adults?
Yes. Yeah. And we also have youth in Wichita.
Right. With, or now,
KBC.
the KBC, right. Now, I believe the other day when I asked the secretary the question on the Wichita, she referred to Via Christi St. Joe, but that's been an existing facility, and I don't see where there's expansion of beds with that.
Yeah,
I'm still
well,
confused.
Yeah, so these aren't necessarily new beds for all the facilities. In some facilities, they would be existing beds that would be uncompensated care. So as part of the SIA program, we're trying to make sure that individuals that would have been referred to the state hospital by Via Christi can now be served at Via Christi. Does that make sense?
Compensated care clients.
Right.
Okay.
Yeah.
All right, that makes sense. Seeing none, proceed.
Okay. So our next one is on the same page. It's 9.2, long-term care access and reform. This is about making reforms within the NFMH system. So as part of our NFMH pre-litigation settlement, we created a plan, strategic plan, to complete this recommendation as part of the settlement or agreement. So this plan calls for several practice improvements that are included in this recommendation, and the actual length of time of the strategic plan that'll take to complete is about 8 years. So we're going to be building this. It'll be in progress for probably quite a while we're working on that. But individually, certain components of that are going to happen faster than that. It's just the longest one's 8 years. We have several that happen in the first couple of years, and then the majority happen within 5 years. But we've also begun our process of reorganizing within the agency and hiring staff to work on those practice improvement areas, and that includes additional concepts that were introduced in other recommendations, like IPS and supported employment, as well as housing and supported housing. Okay.
Oh, Representative Lynn.
Thank you, Madam Chair. Just for clarification, in terms of how patients are assessed, is that patients who are already in an NFMH, did I say that right? MH,
yeah.
or those who are wanting to enter one?
Yeah. So there's two parts to this, right? And the initial assessment is done prior. So if someone is interested in entering an FMH, they first have to meet medical necessity for a nursing facility, and then they have to have a level 2 screen, which determines their plan of care and their needs for mental health services. And then that will allow them to be admitted either to an NFMH on a specialized services plan, or to an NF on specialized services plan, or to an NFMH. And then while they're in the NFMH, we have a review process. So that initial pass-R screen might say, you're good to go to the NFMH for 3 months or 6 months. And then we'll do a review process of that to check in at that point in time to see whether or not they need continued services or not.
And that level 2 screening that you mentioned, that's based on federal regulation, correct?
Yes. Yep.
Okay, thank you.
All right, continue.
Okay. So for page 17 on 9.3, this is around integration for care transition. So we've been working with KDHE to explore our opportunities to integrate care and review the current codes that are in CAN Care. We do think that the CCBHCs and mobile crisis legislation that was passed last session will have a significant impact on this when they are fully implemented. And we're also looking at potential changes for when CAN Care is updated in CAN Care 3.0. And for 9.4, this is around evidence-based practices. We also marked this as in progress. KDADS has established an EBP work group as a subcommittee of the Governor's Behavioral Health Services Planning Council. Additionally, KDADS has begun developing a quality assurance team that will have EBP fidelity reviewers for selected EBPs, and will work to implement those across the system. And specifically, we're working on ACT, IPS, and Housing First as we implement the CCBHCs. I think that's my last recommendation that KDADS is the lead agency for.
Committee, are there questions? Representative Carpenter.
Thank you, Madam Chair. Just very quickly, which was news to me, at Bethel, we had testimony that the nursing facilities, mental health are not Medicaid.
Well, so what the NFMHs are is an institution for mental disease, which is an IMD. And the IMDs are a designation that CMS uses as an exclusionary for participation in Medicaid. So we can't draw down federal Medicaid dollars to provide services within an NFMH. And so last year, as a budget enhancement, KDADS did request, I think, $2 million to assist with providing specialized services within those NFMHs from the State General Fund.
Correct. Yeah. So what is the time length, average time length for folks in?
Well, so let me preface by saying, like, right now it's too long, right? And then that's a large part of the reason we're in a pre-litigation settlement. It's in order to try to reduce the amount of time that people are in those NFMHs. I think our average time right now is somewhere around, I think it's around 6 years.
I just find it really strange that you can qualify for Medicaid, and as soon as you go into one of these facilities, you do not receive any Medicaid, and we receive no payment. The day you come out, you will qualify for Medicaid again. Mm-hmm. How weird is that?
Yeah.
Government at its best. Representative Ballard.
Thank you. Actually, Representative Landwehr had made a comment about acronyms, and I was just listening for this one. The IMH has to agree with the FMH and all of that. Now tell me, what's the IMB?
The IMD. So the IMD is the Institution for Mental Disease, and that's essentially a federal definition that means that more than 50% of the people that are in the care of that facility have a mental health diagnosis and are being treated for that mental health diagnosis.
Now that's a new one.
But the nice thing is, I have utilized this sheet several times as he was talking. And that definition is on there.
I should have been looking. Thank you.
Further questions? Seeing none, thank you very much, Andy. Appreciate it.
Thank you.
Okay, next we have Department of, Office of the Governor, presented by KDADS on behalf of, was that yours, Andy, as well? Okay, so that I get to check off two. Next, I have Sarah Fertig, the Medicaid Director, and I believe she's coming in virtually. Is that correct, Sarah?
That's right, Madam Chair. Thank you.
All right, welcome.
Thank you. And good morning, committee. The first item for which KDHE is listed as the lead agency is item number 1.2. This was the recommendation that KDHE commission a study to explore strategies to increase the number of psychiatrists, child and adolescent psychiatrists, and psychiatric nurses. This study is currently being explored by KDHE. Our Division of Public Health does have some existing contracts, and we're trying to see if perhaps that study could be funded through an existing contract within existing appropriations. But I would add that the Kansas Recruitment and Retention Center through the University of Kansas, they do have some ongoing activities geared at workforce, including these licensed professionals. And the KRRC maintains a webpage that includes financial incentives and various programs, loan forgiveness, things like that, that are kind of geared at that. And I would also add that on the Medicaid side, we are evaluating whether we can more fairly reimburse psychiatrists for psych consults that they do on behalf of Medicaid beneficiaries.
So
And
when we're
Madam
talking
Chair-
about, yeah, when we're talking about exploring whether this study can be done, are we any closer to an answer? Because this would be from almost a year ago.
Sure, and there are some ongoing work that the Public Health Division has within that existing contract. They're checking to see if there's any bandwidth left in the contract so that we could accommodate that within existing appropriations.
So when will that be completed?
I
When will
need
we
to
know an
reach back
answer
out.
to that?
I will need to reach back out to Public Health and see if this is something that they've decided that they can accommodate within their current contracts. Otherwise, we would probably need to RFP for that particular service.
All right, thank you.
Mm-hmm.
Proceed.
And on item 1.3, KDHE was not listed as an action lead on that. This had to do with increasing capacity and access to medication-assisted treatment in Kansas through provider training on MAT. And I just wanted to add that both KDHE and KDADS did work with the Department of Corrections on a technical assistance project that was sponsored by the National Governors Association on MAT for the justice-involved population. So this has been a hot topic for the three agencies.
Okay.
The next item for which KDHE is the lead is item 2.1 on page 3 of the log. And this is the CCBHC model. And for those of you who are with the Bob Bethel Committee, you heard a bit of an update on this last week, but this project is very well underway. We've been meeting with the CMHCs on a weekly basis since mid-July to launch this project. And we have a very ambitious timeline to get everything done, and we are tracking to that timeline.
Continue.
The next item for us, just a quick comment on item 2.3. This had to do with a rate increase for behavioral health services. Just one item that we wanted to add is that once the CCBHC model is fully implemented, we anticipate that it would result in about a $40 to $70 million a year increase in funding to CMHC. So hopefully we'll see some movement once the CCBHC model is launched.
All right, now, Sarah, when you quote that $40 to $70 million, that's assuming that we have all of our CMHCs become CCBHCs. Is that correct?
That's correct, Madam Chair.
All right, because actually what we're bringing online this year is our first 6.
That's correct, Madam Chair. So yeah, once it's fully launched and assuming all 26 decide to pursue CCBHC certification, that's what we anticipate the annual influx of dollars will be, about 40 to 70 million.
All right, thank you.
Mm-hmm.
Proceed.
So the next for which KDHE is a lead agency is item 3.2, and this is IPS community engagement. And I would concur with the information that Andy Brown shared and would add that we did launch the STEP program, which is based on IPS principles. This is a supported employment program for individuals with certain qualifying behavioral health diagnoses and also those who are on the IDD waiver wait list. And we include in our response the IPS principles that are included in the STEPS program. And if there are no
I'm
questions.
sorry, you couldn't hear me because my mic was off. Go ahead, proceed.
The next item for KDAT's response is item 4.2, early intervention. And this recommendation pertained to early childhood mental health services and SPA language. And we're reviewing this currently, and we're trying to determine what the fiscal impact would be.
Do we know when we'll have an answer on the fiscal?
I will check back with our data team and see where they are on that.
Thank you. Proceed.
Then item 5.3 concerning frontline capacity. And this recommendation is to increase capacity of frontline healthcare providers to identify and provide services to those with behavioral health needs. One of the projects that KDHE sought with the ARPA Section 9817 funding, this is the 10% FMAP bump money. One of the projects that KDHE is seeking to pursue is to commission a training to better equip providers to provide services to HCBS individuals, and that would include those with behavioral health diagnoses. We have not heard back from CMS on those projects, so they're currently pending CMS approval.
I'd ask you how long that was, but we never know with CMS.
That is very true, Madam Chair. However, KDHE and KDADS jointly submitted our spending plan for that project on July 9th. So
All right,
we're
thank
going
you.
on 3 months of waiting. The next item for KDHE's response is on item 7.3. And this concerns information sharing. I can't speak to KHIN. I don't know if they're providing a separate response, but with regard to the recommendation to use Medicaid funds to incentivize participation in HIEs, this is another thing that we're looking into potentially as part of the CanCare 3.0 RFP, but it's something that we're studying currently.
Proceed.
And let's see, on item 7.5 on page 13, thank you. So we were not identified as an agency lead on this, but just kind of a side comment that KDHE, we're planning to pursue legislation in the 2022 session that would allow us to access KTRAC's data so that we can provide reports to the federal government in accordance with the Support Act. Effective October of this year, prescribers who prescribe controlled substances to Medicaid beneficiaries are first going to have to check the KTRAC's program before they prescribe that substance. And beginning next year, we will be required to do some reporting to the federal government concerning our compliance. So we require a statutory change in order to gain access to that information, but that will improve cross-agency data coordination.
So does that mean that you have a bill in progress?
Madam Chair, there was a bill introduced last year by the Board of Pharmacy, and we've spoken with the executive director, and she would be amenable to a friendly amendment. However, if that doesn't move forward, we can pursue our own legislation for that. The next item for KDHE's response is item number 9.3, integration. That's on page 17. And Andy shared quite a bit of information on this, but I just wanted to add that, we are in the process of launching the CCBHC certification program in Kansas. And we've also worked with KDADS and DCF to launch mobile crisis response services for youth. And that goes live, oh boy, in a couple of days. That goes live in October. So I can't believe it's here already. So we are working on that.
Okay, go ahead.
And then at the bottom of the same page, item number 9.5, this is a recommendation to open up code 90846. And we agree that we need to open this code. And so our response includes the three things that we're currently working on. The fiscal impact, what state plan amendment language we would need to include to enable CMS to approve that state plan amendment to cover that code. And then we're also looking at what this code means in the context of the CCBHC model. And that's part of the discussions we've been having with the CMHCs every week. So that's fully in process.
Do you anticipate that we may have information on that by the time the session starts?
Yes, I would imagine so, Madam Chair. We've been reaching back out to CMS, and just a little bit of background for those folks who were not on the committee last year, maybe they don't have the background on this particular code. This is a code that would allow a therapist to meet, for instance, with foster parents to discuss home structure or rules, things like that, to help benefit the child. So it is family therapy geared at the child. However, the child is not present in the room while the therapy is going on. KDHE had reached out previously to CMS to see what would be required to cover the code. CMS responded to us that this is a code with a high potential for fraud, and therefore they were going to require a lot of state oversight of that particular code, and that scared us off a little bit because I'm not sure the CMHCs would particularly like that either. What was confusing to us, however, is that other states were not subject to those same stringent requirements. So we've been trying to figure out why they were treating Kansas differently. So we're reopening those conversations with CMS in the hopes that we can have a state plan amendment that they would approve that looks more like state plan amendments in other states that do not have that very strict oversight for that code.
Yeah, that would be interesting to know. Thank you.
Mm-hmm. And then the next item for KDHE's response is item 10.2, reimbursement codes. And this is a recommendation that we maintain reimbursement codes open for telehealth delivery after the pandemic. And we completely agree with that. KDHE has no plans whatsoever to roll those back. Our caveat is that this is subject to CMS continuing to allow us to draw down federal funds to help pay for the cost of those codes. There would be a fiscal impact if the recommendation is adopted to require payment for facility fees when the patient is at home. And we also imagine that non-behavioral health providers would also want to be allowed to collect a facility fee for telehealth services that are being delivered to a patient while they're in their home. And just for a little bit of information, Madam Chair, I asked our data team to look into how many telehealth claims there were in calendar year 2020 for behavioral health services. There were about 542,000 telehealth behavioral health claims in calendar year 2020. A little bit fewer in 2021. That could be because, the darkest parts of the pandemic were maybe beyond us now. We're not quite sure on that, but the volume of claims that would be impacted by that facility fee is large. And so we would imagine that there would be a significant fiscal impact for that.
Well, and I think that, yes, it's one of the reasons that one of our working groups is dedicated to strictly the telehealth issue.
Indeed, indeed.
Thank you. Go ahead.
And the next item for us is right below that, item 10.3, telehealth for crisis services. In our response, we include a citation to 2 bulletins for the Kansas Medical Assistance Program, where we authorize the use of crisis codes via telemedicine. So we've marked that as completed.
Sarah, while I've got your attention on this, and I'm sure there'll be discussions, I'm not quite sure. It's my understanding that Oklahoma, with their CCBHC model, that they're actually using some tablet technology as some of their that their officers will have access to maybe directly connect a individual with a mental health specialist. right on the spot. So if you could maybe check a little bit into that for us as we proceed our discussion as to how Oklahoma might be paying for that, because I would assume it's not coming out of just the CCBHC budgets. I would assume there's some kind of a Medicaid match or a possibility for that, so we might go ahead and look at that.
Noted. Thank you, Madam Chair.
Thank you. Proceed.
The next item for us is item number 10.5 at the bottom of this page. And this again concerns telehealth and using telehealth to main service and provider continuity for kiddos, particularly foster kiddos as they move around the state. We absolutely agree, and we recognize the value that telehealth provides, particularly in a very largely rural state like Kansas. And again, we have no plans to roll back those telehealth flexibilities that were created during the pandemic, with the caveat that if CMS rules change, we will need to change as well, because we need to be able to draw down federal funds to pay for those services.
All right. Thank you, Sarah. Are there questions for Sarah Fertig on anything that she's covered that maybe came to mind? All right. Seeing none, we look forward to working with you on this issue as we go forward, because that telehealth is going to be a major issue, whether it's dealing with the private pay side of it or the Medicaid side of it. So thank you, Sarah. Appreciate you being here today.
Thank you, Madam Chair.
All right, next I have Tanya Keys, Deputy Secretary for Department of Children and Families. Welcome to committee. It's been a while.
Yes, thank you very much. Hi, committee. Thanks for letting me be here. I'm Tanya Keys, Deputy Secretary. DCF has three lead pieces that we can talk about today. First one is 3.3 foster home, starts on your page 7. We have this as in progress. It's in terms of current investments, as I think you've heard a couple of times today, we are starting the family crisis response and mobile support. That starts October 1st. That'll be a support to placement providers. We also supported caregivers through our collaboration with KDADS to create, and a work group to create the guide for psychotropic medications. That has gone on. We also have, although uneven or incomplete, we do have some of our case management providers who are using trust-based relation intervention, TBRI, is sometimes how folks refer to it. In terms of recruitment and retention around some of these pieces, DCF contracts with Children's Alliance of Kansas, and they have a host of curriculums and resources available to caregivers that they can sign up for online. And it's sort of interactive on their website that they can sign up. I've listed a few of the items in terms of cognitive behavioral interventions, de-escalation techniques. There's so many more as well. The Children's Alliance of Kansas does offer. Recently, they started and implemented the new curriculum called Core Teen, which is a 14-hour course that really focuses in on challenging behaviors and helping with coping and supports for that. In terms of increased funding, DCF increased funding for supplemental training to Children's Alliance of Kansas around some specific curriculums and supports to relative caregivers. Certainly those supports would also be available to other caregivers, but we wanted to think about nationally what's available or emerging that can really help relatives who are facing those challenges. So that just started new. So that would be an example of a new investment.
Questions? Seeing none, proceed.
Our second one is 6.1, which for you is on page 10, domestic violence survivors. Through temporary assistance to families, we have funding and we support a number of small grants through that federal program. Those grants are listed there, for example, grantees, Catholic Charities, Family Crisis Center, Safe Home, the Willow. So that's an example of how we're supporting that piece around conflict resolution training, financial literacy training. They also have a host of supports that they have within their program. A more recent piece in terms of responsiveness around domestic violence and training is we started a contract in January of '21 with the Kansas Coalition Against Sexual and Domestic Violence. It's virtual for us right now. We've already trained a couple of hundred, and this year we anticipate in this state fiscal year that we're in now about 500 of team members, and those might be DCF employees, case management providers, other partners who are working in the child and family well-being system. So those are our, in terms of domestic violence survivor supports, that's what DCF has going on.
Questions? Seeing none, go ahead.
Our third, the DCF is lead, is around crossover youth. There are 2 recommendations on crossover youth. DCF is the lead on this one. In terms of developing linkages, so DCF does have a dedicated full-time staff that's part of the crossover youth model project. That group meets monthly. They have been sort of digging in to ways that at the community level we can increase collaboration, access to services for those communities, and making recommendations for the future in terms of how that project might expand or help families. There's also some work, there's some overlap in functional family therapy that both agencies, both Department of Corrections and DCF offer, and DCF also through the Family First Prevention Services Act does have multi-systemic treatment that we offer to families who have youth in their teens. And in addition, just wanted to mention that, I mean, we are looking at ways to bring more in-home supports to caregivers. So we're looking for those emerging programs. There are a couple that are called behavior interventionists through Cornerstones of Care and Foster Adopt Connect. And we have taken advantage of that and given some smaller grants to small geographies, maybe in Kansas City or other parts. But we'd like to learn more about that so we can make those accessible to families as prevention as well as those in care. And that was on page 11. I apologize.
Okay, proceed.
Those complete the 3 that DCF is the lead.
All right, are there any questions for Tanya? All right, seeing none, thank you very much for being here. Appreciate it.
Thank you.
Next, I had David Fye, the Executive Director, Behavioral Sciences Regulatory Board. Barbara's excited that, or Representative Ballard's excited that you're here, David. I think we still miss you.
Miss all of you as well, and thank you, Madam Chair.
Of course, I think legislative research may not like you right now because you're not with them. But.
Well, thank you, Madam Chair. Members of the committee, my name is Dave Fye. I'm the Executive Director for the Behavioral Sciences Regulatory Board, and we were asked to provide a response in regards to the recommendations. We were indicated as the lead agency for one recommendation, and there was also a couple I wanted to provide some comments on because we were one of the key collaborators. So the first is on page 1. It's actually your first recommendation, 1.1, clinical supervision hours, and we do have that marked as complete. Your recommendation was, when applicable, reduce the number of clinical supervision hours required of master-level behavioral health clinicians to obtain clinical licensure from 4,000 hours to 3,000 hours, similar to the reduction in clinical hours of social workers. And just for reference, the change for social workers was made by the 2019 legislature. I'm happy to report that for the 2021 legislative session, the board of the BSRB requested introduction of a bill. That was House Bill 2208, which was enacted. And that bill did decrease the number of hours of supervised professional experience from 4,000 hours to 3,000 hours for the professions of master's level psychology, professional counseling, marriage and family therapy, and addiction counseling. And although it's not one of the items on here, it does involve the supervision hours. There was also a number of direct clinical supervision hours for those individuals, and it was at 150 hours in statute. The social workers was reduced to 100 hours. So in the bill that was before the legislature this year, it did also reduce those number of clinical supervision hours from 150 to 100. And we believe that puts it in more in line with the other states in terms of their hours. Would you like me to move to the next recommendations? Okay.
Yes, I don't see any questions.
Great. On page 2, On page 2, there was a recommendation number 1.4 that had to do with the workforce investment plan. And we have this, at least as far as the BSRB is concerned, as far as in progress. We were one of the agencies that was listed as a key contributor or collaborator. And we just wanted to highlight a couple things for the committee. We are primarily a public protection agency, and so our funding is limited in terms of how we can contribute to this area in terms of workforce investment plan. However, we do work with different universities in terms of information. We also work to help license individuals who can qualify for those practitioner level positions. We oversee 7 different disciplines of professionals. One of the items in the recommendation talked about a career ladder for clinicians, and we do offer a tiered approach to licensure with several different levels. For example, for social workers, there's a bachelor's level, a master's level, and a clinical level of social work license. One of the items in the recommendation talked about consideration of an associate level license. And that is one thing that the board has had some preliminary discussions about. Years and years ago, we did license individuals at an associate level social work license. In fact, there's still about 8 that have been grandfathered in and continue to be renewed, but we do no longer offer that as a license for individuals. But that was ended over 20 years ago. So we're in the process of looking into some of the history of why that was ended. But we did want to highlight for the committee that there are other areas where individuals who don't maybe have the 4-year degree can help out in the mental health field, such as the behavioral health, mental health technicians, or perhaps as a case manager, or other services like that. But we are having ongoing discussions as a board and for the advisory committees that discuss the board or work with the board.
Well, and I think, David, that's a big part of what we really want to take a look at this year. So I'm glad to see that you guys are already reviewing this because, and maybe it's something within our VOTEC side in our high school that, we can start some of these young individuals off onto a path that they might see that social work, and then, of course, they'll have to decide what area. But maybe that's how we kind of start growing some of our own folks that we have here because like you heard me say earlier, there isn't an area of healthcare we don't have a shortage in. And this one is huge because this is the one that's escalated. Those 500,000 plus that Sarah talked about last year was astounding. So look forward to seeing more information on this and anything that we can do from a legislative perspective. And if we can do it next year, we'd love to have that opportunity.
Okay, that sounds great.
Thank you.
One of the other items that...
Representative Erickson.
Thank you, Madam Chair. Thank you, David. Just a quick question. I notice in the response that there's discussion whether to change CE hours to require training in DEI. Is there an update on that discussion?
Yes. We have an annual planning meeting for our board because of the issues around the COVID variant. We've broken that up into 2 meetings. So we had one of those yesterday, and we have another one for October 25th. We've had some of the representatives of associations approach the advisory committees for the board and request that there be a change to require continuing education hours in those 3 topics, diversity, equity, and inclusion. And some other states are also evaluating that topic currently too. Right now, for at least the highest level, we require 3 hours of ethics and 6 hours in diagnosis and treatment. And so we're trying to, the board is currently looking at, is there a way to recognize those hours that would qualify for diversity, equity, and inclusion without requiring too many hours for professionals, without giving them flexibility to choose things in their area. So the board is trying to weigh different options right now as far as should those hours be included? Is there a way to maybe satisfy more than one criteria? But that is something the board is having an ongoing discussion about.
Thank you, Madam Chair.
Continue.
And Madam Chair, there's one more recommendation that I wanted to touch upon, and that's on page 18. On page 18, there's a recommendation 10.1 quality assurance. We were one of the several different entities that was identified as a key collaborator. So we tried to provide a fairly comprehensive set of information here about how some of the things the board is looking at currently might relate to some of the items in this recommendation. One talked about establishing consistent guidelines and measures for telehealth in collaboration with licensing and regulatory agencies. The field of telehealth, or the area of telehealth, is definitely expanding, and there are ongoing conversations at the national level in terms of the different associations. In terms of a consistent guideline, that is still, there's a lot of variability state by state. So there are upcoming meetings of some of those associations where they're looking at some of these elements. Also, there is a movement of multi-state compacts that have consistent criteria between different states in some of these areas. One that had come before the legislature during the 2021 session was SIPAC, and that's for licensed psychologists. There is another one that is going before different states right now in the field of professional counseling. And then recently, about a month ago, there was an initial meeting for social workers to start to develop a multi-state compact there. So we are actively playing a role in those discussions. Kansas will join the SIPAC Multi-State Compact on January 1st of 2022, but we're able to attend those meetings for discussion purposes before then, so I will be attending that meeting in November. And so we're going to be continuing to look at those and bring back any recommended changes we need to bring before in statutes. We're also looking at our regulations to see if those need to be updated for more of an idea of telehealth services. A lot of those were written primarily under the idea of face-to-face type services in person. So we're looking to see how many of those might need to be adjusted and how we can adjust for this telehealth area.
Well, and I think, David, those compacts we're already starting to see where they're kind of, playing a big part. I know with the nursing compact, that was a huge boon for us with the shortages that we're having. So that'll be interesting to see what you come back with. Are there questions, comments?
And Madam Chair, I just wanted to touch upon one thing. I don't want to interrupt any questions, but
you're fine.
One of the items below did talk about allowing telehealth supervision hours to be consistently counted towards licensure requirements. And one item in the bill that I referenced earlier, that 2208, did allow for televideo supervision for all the professions under the BSRB, with the exception of licensed psychology. Their statutes and regulations were worded a little bit differently. Their regulations say it can happen no more than 1 out of every 4 supervision occurrences. So we've talked to their advisory committee. They've recommended a change. The board has concurred with that, and so we're in the process of putting in new language to allow all supervision to be over televideo or in person. So we're working on that flexibility, but for the majority, that's pretty much completed.
So is that going to require legislation, or is that done through rules and regs?
And that will be done through rules and regs.
All right. Representative Ballard.
Thank you. You answered part of a question I was going to ask. You know, when you talked about the supervision hours reducing from 4,000 to 3 and the 150 hours to 100 hours, I hope that has proved to be helpful, especially with the workforce shortage that we have already. And so, I mean, when we did it, we were thinking about that, but I think it's even more crucial. So I hope that was really helpful. And I just wanted to be able to explain a little bit why we were so enthusiastic about your coming up here. That is not to slight anyone who was presenting today, but we had worked really close with David on social services, and Representative Carpenter and I looked at each other, and as well as Representative Lanwell, when you came up, it's the first time we've seen you in your new capacity. So that was our enthusiasm for anybody who may have felt flighted, but delighted to see you today.
Thank you.
Actually, I got to abuse him during the session, Representative, in Health and Human Services.
That's terrible that you got to abuse him.
He asked for it. Senator Hawk.
David, likewise, good to see you. In the collaborative responses on your 10.1, you mentioned, and I think you pointed out a real problem in that we don't have adequate broadband in several places in Kansas, and we're working on that. But you mentioned that you tried to include language that would allow supervision over the telephone if you didn't have adequate broadband. Does House Bill 2208 give you statutory authority, or do we need to change that to give you authority to do that?
Thank you. That was something that was also included in 2208. So it's not a direct link in terms of the services being provided, but we think it will help speed up the time frame in terms of individuals meeting their requirements for supervision and then become clinical level practitioners and be able to provide services quicker. So that is already taken care of in 2208. And Madam Chair, I just want to mention one thing. So in terms of the different items on here, there was a note someone brought up about the number of hours reducing from 4,000 to 3,000, and the board does appreciate the need for that to be implemented quickly. In the past, changes like that may have needed to include a update to a training plan, but the board recognized they wanted this to go in as quickly as possible, so they waived that requirement for practitioners. So anybody who was currently under a plan that was under the 4,000 hours was able to move immediately to that new standard of 3,000 hours. And once they met that and the other requirements, they were able to move forward.
That's great news for us. Further questions, comments? All right, seeing none. Thank you very much, Dave. It's good to see you again.
Thank you, Madam Chair.
All right, next I have Randall Bowman, Executive Director of Public Affairs, Kansas Department of Corrections. Welcome to committee, Randall. Fortunately, I don't deal with your stuff a lot, so this is a new one. Welcome.
Well, thank you, Madam Chair, members of the committee. It's a privilege to be before a little bit different committee for us, of course. And everybody's covered it so well, and I guess I have to follow David. That's the hard part. But just two items that our organization, the Kansas Department of Corrections, was listed as a lead organization. I'll touch on real fast. On page 14 of your document, item 8.3, law enforcement referrals. So just in July, you'll note in the little chart there, if you can read it, that we have completed some work with our medical provider, Centurion, and within the department to look at how we have identified when folks come to the reception and diagnostic units at our facilities, and that'd be males at El Dorado, females here at Topeka, and of course children here at Topeka, so that we can better make those referrals within our own network in providing services within the organization. And then also we have been working on the community side of that as well. It's been long-standing practice that we work with the regional alcohol, drug, and assessment centers through our parole staff and encourage community corrections on the juvenile adult side to do that with probation as well. So we have reviewed that for parole and made sure that we have the right processes and trainings in place for those staff to make sure they're making those referrals out to those organizations and community. So that's, again, for those of you less familiar with the correction side, so they come to prison, then they're going to out on parole for a period of post-release supervision, and they're going to consume services in the community there, and they're not going to consume services provided by the Department of Correction as they do when they're in the facility. With that, I may pause on that one.
Questions, committee? All right, no, thank you.
Very good, Madam Chair. 8.4 is the other, and crossovers come up in a few different points in the conversation here today. But this one specific to the Department of Corrections focused on the definition of what is a crossover young person. And so as recommended by the Juvenile Justice Oversight Committee, the Kansas Department of Corrections contracted with Georgetown University McCourt School of Public Policy's Center for Juvenile Justice Reform for the implementation of the crossover youth practice model here in Kansas, and that's funded by the Evidence-Based Practice Fund. So that contract's in place. The work is underway on that. And at their July 28th of this summer meeting, they agreed to a definition that Representative Ballard, I think, referenced earlier in one of her comments. And I just encourage folks to focus in on the word concurrent in that definition. So we're looking at that small group of young people who, as Andy said, are very, very needy, do have a significant risk for staying in the justice system or really coming over to us on the adult side one day once they cross that age barrier. So it's a small number, but now that we have this definition, and as the other work in this report and others around data and some of those things advance, then hopefully we'll have a better chance to measure that more accurately and effectively for everyone. That committee, as Tanya mentioned, continues to meet on that work. There are 3 statewide coordinators, one in the Office of Judicial Administration, one in the Department for Children and Families, and one in the Kansas Department of Corrections, who are working to advance this work on crossover youth. And the last element I wanted to share today with this is there is the statewide policy committee that's looking at how do things work, what barriers exist in law and practice and internal agency policies. The other part of the model is communities to then work on that process locally. And we have Shawnee County and Montgomery County working a pilot project starting from square one. Then we have Sedgwick County, who had dabbled in this work about a decade ago with them and made a lot of progress, but we're kind of refreshing that work as well. So that's the third community working at the local level on this topic as well. And with that, I will conclude unless there's questions.
Committee questions? Just back to the definition, and I noticed that the definition is 10 or older versus maybe the 10 to 14.
Yeah, so it's capturing all those that would be 10 and up in the can concurrently be in the child welfare and juvenile justice. So it'd be the 10 to technically 17 in your 364th day that you can concurrently be in those systems.
Okay, thank you. Any further questions? Senator Erickson.
Thank you, Madam Chair. Just quickly, there's a statewide policy team referenced. Do you refer to that as the SPIT team?
That is the, let me look at my notes here. Yeah, so the statewide group is 29 members. So it's just the statewide implementation team for the crossover youth practice model. And there are membership from the courts, Department of Children and Families, the private contractors, the State Department of Education, local school districts, law enforcement, health departments, and service providers, and of course the department.
And those 3 statewide coordinators you referenced are part of that?
They work with
SBP
that
or SPIT team?
statewide group, and then
Okay.
those 3 people are employed by each agency, working across the agencies and with this board and with the pilot sites in those 3 communities.
Perfect. Thank you. Thank you, Madam Chair.
Thank you, ma'am.
Committee, further questions? Seeing none, thank you very much, Randall, for being here today.
Thank you. Glad to be here.
All right. Last but not least, I have Craig Newswonder with the Deputy Commissioner for Fiscal and Administrative Services, Kansas Department of Education. Welcome to committee. It's good to see you in person again.
Good morning. Thank you, Madam Chair. It is good to be here in person. Seeing people live and in person is always an advantage. We just have a few items on the list for which we are collaborators. And the first one is 4.3, which you can see was marked off as having been completed already. The statewide coordinator, centralized coordinator. Right underneath that is 4.4, dealing with behavioral health prevention and state funds for some of those programs. We channel, for lack of a better word, the funds for psychiatric residential treatment facilities, juvenile detention centers, and Flint Hills Job Corps by formula. And I just let you know that, not a surprise, I'm sure, last year in 2021, the number of students in those facilities declined, and that had to do, according to those facilities, largely with COVID. Both students who were not able to participate, and in some cases, limits in the facilities as far as space that they had available. So we anticipate that that will increase again this year.
Okay. Committee questions? Seeing none, proceed.
Okay. The next one we have is 7.2, and that has to do with the data surveys and the question on any surveys, at least in school districts, when they are given is opt-in as opposed to informed opt-out. And this recommendation was to pursue the informed opt-out. And the organizations we work with, the School Mental Health Advisory Council and the Blue Ribbon Panel on Bullying, both agree that the informed opt-out would be very helpful in terms of data collection. And you see the recommendations there from other organizations as well.
Questions, committee? Seeing none, proceed.
Okay. And next, and the last one I believe I have, is 7.5, encouraging state agencies to collaborate and work together a little bit better. And I just gave you a few examples of some of the things we do with some of the other agencies and how they work with us. DCF, we have had a relationship with for quite some time. They do provide a daily file to us of those children who are in foster care, which can be very helpful. Otherwise, school districts sometimes do not receive that information until quite some time later. They also help us, DCF does, with background checks on applicants for teaching licenses, which helps that process move a little quicker and a little better applicants for teaching licenses that way. One thing I think I can say, if one good thing came out of the pandemic, the relationship between KDHE and KSDE has, I won't say improved, but it's really good because we met weekly, their leadership and our leadership, via Zoom, just to touch base. What do school districts need to know? What KDHE need to know about what was happening in the schools? And we were able to get quite a bit more information out to our school districts in a timely manner than we would have been able to otherwise. So that, you know, some people will tell you you don't want to waste a good pandemic. In that particular instance, I don't think we did. We were able to benefit from that relationship and the working relationship that we formed with them.
I'm always kind of the opinion, Craig, that, you know, any negative has a positive. You just sometimes really have to look for it. And I think, you know, like telehealth, for example, was one of them that's come out of COVID. It expedited it a lot faster than it probably would have otherwise. So, yeah, we can always find positives out of the negatives. Are there questions for Craig, committee? Senator Hawk.
Thank you. Good to see you, Craig.
Thank you.
It's only been 20 years since I've had to deal with student records, and my recollection is in the olden days when I was there, we often would get foster kids, and it would be a long time coming to get their student records transferred, and oftentimes foster kids, when they went into the foster care system, got assigned to a home that was away from the current school district. I assume that has improved greatly with the electronic records, but what is the status of that?
Your assumption would be safe. It has improved. I'd like to tell you it's perfect, and we always have the records right there when they walk in. It doesn't always work that way. Some of that, and this is Craig's opinion now, is the nature of the way things have to work when sometimes students have to move in a hurry late at night. But it is much better, like you, compared to the olden days when I dealt with it. We do get the records much quicker than we used to, but it's not 100% yet.
It would seem if we could improve that. I know a lot of times those students get a really rocky start, and some of it is if the counselor or the teacher knew what the problems were better, and I'm happy to see that at least that foster care report card is getting there, but it would seem to me that ought to be something that in today's electronic age we could improve on potentially. So thank you. Thank you, Madam Chair.
I think that was referred to as the red folder, wasn't it, that followed the kids?
Yes.
Now, Craig, we talk about the electronic records, but we have some rather large school districts that still aren't doing electronic records. Would that be correct?
I believe it is, but I couldn't tell you which one specifically.
Well, and I can't say for today, but I know back, and we're what, year 4 of the K-12 mental health program, I think?
Yes.
That the largest school district in the state, Wichita 259, doesn't have electronic records.
Okay.
So I think that that's something that if I was the Department of Education, I would be very interested in working towards making that happen. Because as what Senator Hawk said, the problem that we have, and we've heard this from our schools, is a child shows up that's had to be moved, gets put into mainstream, and that's probably not where they should have been. So the next thing you know, then we have a child acting out, but it's actually the adult's fault because we put him or her in the wrong place at the wrong time. Yes. But we can also then end up having them show up in our juvenile justice system. And again, that's on us, you know, because we put the child in the wrong environment. So I'd really like to see the Department of Education put a bigger focus on that. And it's surprising to me as we go through all of this here that there's zero mention of the K-12 mental health pilot program, which you've been there from the very beginning of this, as have I, and I have concerns that it's not growing at the rate that it should. I have concerns that perhaps there's a lack of interest of funding from our school districts out there. You know, I think it's something they're wanting the state to pick up the whole tab for, and that was not going to be the intention going forward as a pilot. Yeah, we had to do that because we didn't know exactly what we were dealing with, but now I think we have a much better handle on that. And it's concerning to me that that program could end up disappearing for the lack of interest outside of perhaps one legislator that brings it up year after year, and she doesn't plan on being here that long. So I was disappointed that the Department of Education struggled, and I know that this goes back to the board, of adding additional funding, which they did a small piece of it, but it wasn't a priority for them. And this mental health piece, this is impacting these kids. And, you know, every day we hear about, you know, if a child dies of COVID, which we had a middle school child die of COVID, but what we haven't heard is the suicides of our kids. And I talked to a legislator the other day in her small town, 3 this last year. Those are big numbers.
Yes.
And we know, you've seen the chart, because this is a, and I don't know, Senator Hawk, if you're familiar with this program, but there is a quarterly report that comes out, and it is data-driven. So we can monitor every one of these kids, and even if they bounce from home to home to home. And the priority, the alpha kids, were always supposed to be the foster care kids. But I'm not sure that we're getting as much as we should with those kids. So you don't have to respond to me now, Craig, because I'm not trying to put you on the spot. But I have had a discussion here in the last couple of weeks with one of your staff members, you know, expressing my frustration on this here, with the frustration that the school districts aren't seeing this as a benefit for their kids, and they're not seeing it as a money-saving benefit, if nothing else, to where it frees up some of their funds, because they're hiring social workers like crazy. And the thing that makes me madder than anything is they're hiring the social workers from our CMHCs that are in there doing this program. So now, instead of a child having access to a professional like they should 24/7, 365, they only get them when school is in session. And you and I both know that's not when all of our crises are happening. So you're going to hear a lot from me during the session on that. So that's just kind of my preamble. So I hope that, you know, your office, along with our Board of Education, really takes a hard look at that between now and the time that the session starts, and decide if it's an investment that they want or if they're prepared for the program to go away.
Thank you, Madam Chair. I would just share one piece of information for you, funding-wise, because ESSER funds for school districts so far, and there are more to be drawn down, so far school districts have targeted $16.8 million for mental health services. Not necessarily for the mental health intervention program, but for those services.
And those services means hiring more social workers.
In some cases, yes.
Into their schools. And so, you know, I think it would be interesting to see an analysis if we, because I learned a lot about the breakdown of salaries depending upon what level of social worker we were dealing with, because originally we started with the master level. And then we found out we don't need a master level social worker in there as our liaison, for example. And so we brought it down to anyone with a bachelor's degree, because that's more of a coordinator. It's not one that's providing clinical services. But I just think that our schools are, you know, I'm glad to see that they're putting some more money into that, but are they putting it into the right places wisely when there's a program out here that perhaps that money could be funding, and take some burden off of them, keeping in mind that K-12 mental health pilot program bills more Medicaid codes than a school can. And I've looked at the codes that the schools can bill, and you and I know that they're pennies on the dollar. Maybe it's only $1. They cannot bill CHIP, which is the children's Medicaid program. They cannot bill private pay insurance, which this program can. And then we also have a small portion of funding in there for the uninsured. 24/7, 365. So, yeah, I'm working up my passion on this here. So we'll be having a lot of discussions, Craig, and I know you've been a big supporter of this, as was Dale Dennis. So we look forward to it, and you can take that message back loud and clear that I'm on a rampage.
I look forward to working with you as well, ma'am.
Are there other further comments now that I've had my diatribe? Okay, I've got Representative Ballard and then Senator Hawk.
Well, you know, I think because
Senator Hawk.
Thank you, Madam Chair. As a former middle-level counselor who spent a lot of time working with kids over the summer when I wasn't on contract, I appreciate your passion, your advocacy, and a little bit of rampage, because I agree with Representative Ballard. I think it's an important program, and when Senator McGinn lined up the mental health tour, was that 2 years ago or 3? My gosh, how time flies in COVID. But we had a chance to visit with some of the people who had worked in this program, and maybe it didn't get in some places a good start, but the reports I'm hearing is it makes a huge difference for a group of kids that we don't often get good access to helping, and they really need that help. So I thank you, and hopefully, I know the state board always likes to listen to legislators, but hopefully we can figure out how to get significantly more money in that program and make sure it is institutionalized for the next group of legislators that are coming along. Thank you.
Well, and Senator, I'd be happy to sit down, with you or anyone else that wants to look on, because this whole thing started, it was very bipartisan. It wasn't a partisan deal. And it actually came out of a discussion that I had with, at that time, the lobbyist for Wichita 259 and visiting one of the schools in my district and visiting with the social worker and hearing the word disconnect, disconnect, disconnect every time she said something. And that disconnect being a child not having the same counselor as much as possible, because building that relationship, you can be a great counselor, but if you don't connect with that child, you're not really going to be able to do a lot for them. And so that, that piece was very important. And the idea being that is that, we can, draw down with our Medicaid match and just do much more with it. But it really takes a collaborative desire and working agreement. And I know that we've got school districts across the state that had programs that they felt were more efficient for them, and I understood that, so I don't have a problem with that. But those that don't have it, this is just, the success has you can't deny the success in this. And every time I hear about a child that we prevented from committing suicide, it's exciting. Last year we heard testimony of one of our liaisons talked about a young kid that they were concerned that there were suicidal tendencies with him, and they had a visit with him and got him home and thought everything was fine until he came in the next morning and brought copy to a couple of his teachers. And they found a note, and they prevented him from dying. So, yeah, it's powerful. But we need more legislators to decide how important this program is in their districts, because it's not about Representative Landwehr. It's about the kids. All right, Craig, thank you so much. I didn't see anyone else on, well, let me double check one more time on Zoom. I'm not sitting here just playing with my phone and reading it. I am looking for for people texting me that I've got Zoom folks out there. So thank you very much, Craig, and look forward to working with you this
Thank you,
next
Madam
session.
Chair.
All right. Okay, committee, that takes care of everything that we had for this morning. We are going to somewhat do a working lunch. So for our staff and our committee members here, I don't know if lunch is here yet. I think it was running a little bit late, so we'll go out and check. So I figure what we'll do is we'll break for about 20 minutes, and then we'll try to kind of get back into the swing of things, because I know we have a 4:30 deadline that we're trying to meet, and it's very possible that as we get into some of this other stuff, we're going to have a lot more questions, and I want to make sure that we can fully answer it, because once we finish here today, the working groups start. And that's where KHI, not K and I, but KHI actually come into play, and that's the meat of this whole committee. So we are recessed for the next 20 minutes. We'll be back at 12:20. Okay, we're going to go ahead and get started back up again. Feel free to continue your lunches because I'm going to. This just keeps us kind of on a schedule and versus trying to get out and get back, and that's real hard to do sometimes in this building at 8 o'clock. So, Carrie, are you ready? I think you're our first one up to kind of give us the process for our working group and how that works, because some of our folks are definitely familiar, but we've got new people, and I'm very excited about that.
And good afternoon, committee and roundtable members who are joining virtually. There goes my phone. First of all, I'm going to start with an admission that when the chair asks you to confirm something she says is being correct, it's best to do that, because she was right earlier when she said that the mental health task force met in 2017 and 18, and the reports came out in 2018 and 2019. So my apologies on the spot there. I got my years wrong. Time flies, especially with COVID-19.
Well, yeah, but you were working on them, so you had that right. But that's when, and the only reason I remember that is because I read each one of those. And I found that history that you provided in there of why this was structured this way, why this one was structured that way, how did that money flow. It was great information, so.
Well, thank you. I had a good, and a number of folks who are participating in the roundtable were part of the mental health task force at various times, and the work of many of you in this room or online definitely led to the recommendations and the report that you developed last year. And as we understand it, we think understand the work of the working groups moving forward, and that's part of what we're going to be talking about today, is really to build on that work, not to reinvent the wheel, not to go back and say, boy, well, let's see how we're going to do things differently than we already talked about, but instead really build on that progress that you heard about earlier this morning on many of the recommendations, but then also provide the opportunity for this committee to also direct other topics to the working group's attention. And I'll walk through briefly here kind of the process, but we also wanted to provide the opportunity for folks to reflect upon what they heard this morning. If you've had a chance to look at the crosswalk that KLRD provided, for example, about what other working groups and special committees and task forces have also been working on, and it makes you think, gosh, there's something that this group could also be looking at that could really enhance the recommendations. There'll be an opportunity to talk about those as well. But let me introduce myself real quickly first. My name is Carrie Bruffett. I'm the Vice President for Policy at the Kansas Health Institute. And as the chair said, we've had the honor at KHI of working with a number of task forces and working groups and committees over the years, including a couple years of the Mental Health Task Force, which was established by proviso, legislative proviso, and then administered by the Department for Aging and Disability Services. And then more recently, last year, working with you all on the working groups, helping facilitate the working groups for the Special Committee on Mental Health Modernization and Reform. KHI has been around since 1995. If you've been here for a little while in the Capitol, you've probably been at, to events at our building. We are right across the street, directly north of the Capitol, and look forward to hosting more folks the more we're able to be out in person with each other. The working group's charge, and as in 2020, Chair Landwehr and the previous version of the special committee had asked KHI to facilitate. Do I have slides? Okay. That's okay. I'm looking at my slides. They're really great. You all deserve a chance to see them too. They're actually just mainly words. Thank you. Well, there's me. And then Hina Shah, many of you may recall, my colleague with KHI, who is a facilitator for a number of work groups and task forces, including working with this special committee and working groups last year. She is also, at this very moment, facilitating the autism task team that's been convened by KDADS to work on issues related to youth and adults, but primarily youth with autism or intellectual and developmental disabilities, particularly looking at the cross-section with foster care system as well and the child welfare system, as well as the Medicaid system. So we see overlaps in that work as well as the work that you all have done. The scope that we have discussed this year Hina will join later, depending upon what time it is. She's going to be here to be able to talk a little bit about measuring success and some of the outcomes measurement that we had put in the report last year and get some feedback from you all about what that would look like next year. But that autism task team is still meeting until about 2:30. Okay, am I using the clicker right? That button? While we're getting that going, it really is just a word slide, so you actually aren't missing very much here. You have, as we understand, the charge of the working groups this year, and we look forward to discussing with you as well. It really is to revisit the recommendations from that 2020 report. And when we say 2020, the report I think was dated December of 2020 for the working groups. And revising or updating those recommendations as necessary, as well as considering any recommendations related to new or updated topics that might be directed to them by the special committee. And again, we'll have a chance to talk about some of those in a few minutes. And then with the goal of identifying existing and revised or new recommendation for immediate action or strategic importance. And we'll talk in a second about those definitions. But it was very interesting to hear the updates and encouraging to hear all those updates this morning about the progress on the recommendations. There were, I think I counted 8 total recommendations that were reported as completed. So one of the things we've talked about with the chair is maybe the potential opportunity to go back and think about what did those recommendations have in common that we could help potentially empower organizations that are trying to implement some of the other recommendations to be able to get those fully implemented. Are there ways to sort of prioritize the next things that the legislature, hey, those would be the things you all can really be working on because there's some common characteristics that we think that could advance enactment next year. Or if it's an agency activity, the agency can continue to work on those activities. So I'm going to refer you right now to another handout. It's not going to be on the screen, so hopefully folks have this electronically as well. It's called a scope of work. It looks just like a little Word document, 3 pages. It is sort of a combination of a charter and kind of an action plan, a work plan for what the working group's work can be like this year. So it includes the charge for the special committee itself, and then the discussion we've had is to convene, again, 3 working groups to revisit those recommendations, update them, come up with new ones based on topics that may be assigned, and potentially identifying sort of those things that can really get done in 2022 is sort of the second part of the charge. We have proposed, because we're not starting from scratch, to combine some of the work of the recommendations. There were some the way the recommendations and topics were grouped last year, if you may recall, was in the finance and sustainability, policy and treatment, and system capacity and transformation. We'll talk about how these topics are broken out in a few minutes, but we're proposing to combine 2 of the topics that the first working group had worked on last year with services and what had been policy and treatment, basically to focus on workforce and services. There were a lot of recommendations that were kind of similar or touched on some similar issues. So suggesting combining those so they can look at all of those recommendations as a group. And also having a system capacity and transformation working group, which was similar to the same working group as in 2020, adding one of the issues from the first working group, funding basically finance, to the system capacity and transformation working group. Many of those recommendations were related to system transformation, and again, there were some sort of crossover recommendations. So we'll walk through sort of the technical stuff about that as we start talking about individual recommendations. But we're planning then for those working groups to meet for 90-minute meetings 3 times in the case of the 2 working groups I just described, and then probably 4 times for another working group that will be established specifically around telehealth. So as you heard this morning and as you'll recall from last year, the working groups last year sort of all sent members to a 4th and created a 4th working group for telehealth. And so it was kind of, it was really ad hoc. It was, hey, we realize we all want to talk about telehealth, but let's do that together so we don't have 3 different separate set of recommendations around telehealth. It's our understanding that this year we'll want to dig a little bit more deeply into those telehealth recommendations and probably pick up additional topics in our discussion today with you all for the telehealth group to be discussing, including some of the things that you all talked about in the legislature this year regarding telehealth. The recommendations from this working groups previously were focused very much specifically on behavioral health services. This is the Special Committee on Mental Health Modernization and Reform. But as we understand it, the charge can be a little bit broader for this working group to discuss telehealth issues that kind of cut across service area. So it's an issue of, for example, I know you all have talked about payment parity, for example. That is not restricted to only talking about one kind of service or another. So that could be something that this group would discuss. So KHI would continue to support the work. KHI will provide research support, but primarily facilitation support for the working groups. But it really is the members of the working groups, which is all of you and the folks that are participating online and in the room that are roundtable members, to be able to really drive that conversation. We do look forward to it being it was pretty streamlined last year, right? You guys had a lot of meetings, but they were pretty short and to the point, and they got through it. But we'll have slightly longer meetings, but fewer meetings to try to really focus on the outcome-focused process, to really use this previous report, your current report, as the that work, all of the work that was done before remains front and center. I know the chair last year talked a few times about wanting to think of the strategic framework, the report that you all produced, as a living document. We know that technically a committee only exists for the time it exists, so a report is a report. But one way that we can honor that idea of that framework and the work that you all did as a living document is to use that report and the recommendations as the basis, the framework for the work that's going on this year in the working group. So we really intend to focus the discussion there. I'll pause for a second, and then we can talk about the whole reminder of the immediate action and strategic importance. But I promise we'll talk more about which issues are in which working groups in a little bit. But are there other questions about just the overall idea for working groups this year?
Committee questions, or any of our ad hoc members online that may have questions? I'm not hearing anything. You did a great job.
I'll talk slower. I'm trying to make sure that we can get Hina here to talk about the outcomes and data. So otherwise, you're going to have to deal with me trying to answer those questions. So,
no, I think we'll be able to get to her. So
okay,
good.
Okay, good. So on the next page of the slides is the recommendation designation. Just a reminder, and we did talk about it this morning, that the way we defined and we, meaning all of you and the working groups, defined immediate action recommendations last year were those that the working groups believed could be implemented within the next 2 years. And so one of those years was this year. So you heard updates on recommendations, some of which were completed certainly within this first year, and others that are still underway or varying degrees of progress. And then there were also recommendations that were considered of strategic importance. So those that needed to be initiated in the near term, but would probably take more than 2 years to get fully implemented. Interestingly, there were a couple of those that were reported as being complete. So they actually were able to be completed within a shorter time frame. But that is the sort of the same approach that we would propose to continue to think about recommendations, is sort of that immediate action and strategic importance, but shifting the lens of immediate action to focus on 2022 and 2023, as opposed to the previous report's framework. So that's our current structure, and we'd be open to discussion about what that would look like moving forward. I can go to the next one. Oh, thank you. So for topics, you have looked at quite a few, or a couple spreadsheets today. I've got one more for you to pull out and look at, but you don't have to read it in great detail. I'm not sure what color I printed out. It's got gray at the top, and it's just a letter size paper. So we can, or you can refer to the slide here as well. So we'll talk about at the topic level and then at the recommendation level, the proposed way that we would sort out topics and recommendations, existing topics and recommendations for the new working group structure this year. So the services and workforce working group, which is largely a combination of the first two working groups from last year, would have workforce, community engagement, prevention and education, treatment and recovery in special populations, have those topics and those recommendations that were prioritized previously. For more details on each recommendation, well, we can look at those, but the spreadsheet here actually sorts each recommendation by potential new working groups. So, and luckily last year we numbered them, so it's not too difficult. The only kind of confusing one is that funding accessibility issue 2 will go now to what last year had been the third working group, the system capacity and transformation working group. So that group will look at funding and accessibility, data systems, the legal system, and law enforcement. And it's encouraging to see folks from the judicial system and law enforcement joining us today as well, because I know that there's a lot of interest from the legislature in recommendations in that area last year. We had some, but probably an opportunity to look at more. As well as system transformation, sort of the big picture system transformation area. So if you add up all the recommendations in those two, so of the current or of the previous report's recommendations, there would be 22 recommendations total in services and workforce. Now, 5 of those we heard today had been completed, so about 17 current ones to look at to potentially revise or update, and then also look at other issues that you all may, or topics that you all may assign. And for the system capacity and transformation, there were 20 recommendations in that bucket, in those 4 topic areas, 2 of which we heard today were completed. So again, similar kind of number of potential recommendations to work through, to look at, to see if they need to be revised to enhance their actionability and so on. And then finally, telehealth, which last year, or in the previous report, had 5 recommendations, but some of the recommendations had several elements to them in the telehealth recommendations. So the telehealth group would be a separate work group moving forward. So that is the idea, and I know it's maybe a little bit confusing to not just keep the same working groups, and that could be a consideration if y'all wanted to direct something in that direction. But given the topics and the way they group, it kind of makes sense to group them this way, and hopefully consolidates and makes the facilitation of the discussions, reduces the number of separate working groups, basically, that may be talking about similar issues, and tries to keep them a little bit more focused. Any questions or discussion about just topics at that level? And then we'll start talking about other topics in addition to the things you heard about today that you would want the working groups to look at.
Are there any questions for Carrie or any of our committee members? And, don't be afraid, for those of you that are online, and even if you're new to this, there's only one dumb question, and it's the one you don't ask. At least that's my philosophy, and that's why I ask a lot of questions. I see you laughing over there, Senator Hawk. Stop it. Because we want to make sure you have a full understanding of this, of what this process is, because it's a little different. And having been through it once, I was really nervous for us to get that going and make it happen, but it couldn't have gone any smoother, so it's going to even be better this year. So everyone's silent. Senator Fagg.
Thank you, Madam Chairman. You're ready for one of these dumb questions from me?
Absolutely. I am.
One thing that when I look at this is accountability. When we go through and we're assessing these different areas, do we address that kind of on each one by itself, or some way to measure? We make all these plans, but to measure and know that we're headed in the right direction, or do you wait till they actually get through the process and they're completed? And then at that point, start assessing accountability. Somewhere accountability needs to be in there somehow. So,
have you been visiting with Representative Carpenter?
No.
No, because, and Representative Carpenter, you can jump in on this, is that he is, along with several of us, are very big on accountability as we go through all of this. And I think Carrie can reiterate, that was a lot of discussion on everything, because people are recognizing that we have to have that, because if we can't measure it, we can't manage it, we can't monitor it, and we can't tell if our money's being spent in the right direction.
Thank you. That's what I'm thinking.
Yeah, so does that help answer? So don't wait till, once you get on the work group that you want to be on, is don't be afraid to talk about that, because that is, as a new idea gets brought up, because you may not have seen it in that spreadsheet, but accountability has to be a big part of this.
Yeah. Okay.
And how do we measure it?
Okay.
And I'm a big proponent of that as well, so.
All right. Thank you.
Other questions, committee members?
May I build on that? That's not a dumb question at all, a very good question, one that was raised regularly by the members of the special committee last year. So it's a good reminder, again, we'll talk about criteria here in a little bit, but one of the things that the working groups tried to do to reflect that concern, or that priority, I suppose, from the special committee last year, was to include in each of in the report, in sort of the discussion of the recommendation, there's a section to identify the action lead and then the key collaborators basically for each of those activities. And so those are the folks you heard from basically today, based on it sort of being assigned out. So if you mean sort of the process step of accountability, like, is this step being done? That was one way. Or is this recommendation being implemented? That was one way to account for it. And then there was also a separate section about specifically measuring impact on each of the recommendations, and so suggestions or recommended ways to measure impact once the recommendation is fully implemented. So one is, what's the progress along the way to getting implemented, and then once we get it implemented, how can we see if it's working? And so my colleague Hina Shah will talk about that a little bit later today, and think about potentially some ways that working groups could be looking at, now that we've heard some measures are implemented or very well in progress to being fully implemented, are there items on the measuring impact we can revisit and think about, oh, well, now there's some different measures we didn't talk about last year that could be included. And that could be something we would focus the working groups on if that's of interest, and it sounds like it is.
Carrie, one of the things is, as we were going through that report this morning, is, and maybe we did it in the full report, because I'll confess I haven't recently read it, is
here if you want to.
Identifying our obstacles. As we rated 1 to 10, what were those obstacles?
Right.
And I know several times, I think, Andy referred to it was financing.
Yeah.
And I think it'll be important if we can, on this, excuse me, and I think staff, this is your work? Okay. Is if we know what the obstacles were, and that's not for you to figure out, that is for the working groups to bring back to us. So why is it an obstacle? And if we know, as we proceed forward, and I don't think we need it in that report, is to understand, is that a $2 million, which, to say that that's a drop in the bucket, it is in the scheme of our budgets, but $2 million is a lot easier to come up with 20 million. So maybe it's something we can figure out how to make those things happen.
Madam Chair, that in that letter size spreadsheet, this will be a tool that the working groups will use, and will then report back to the special committee. So it does include blank spaces right now for enablers and barriers, basically things that, hey, what are things that are going to make this more likely, this recommendation more likely, and what are the barriers? And then the first column of status will be now populated by the same information you heard today from the agencies. So we'll just take that information and complete that and fill that in. So that'll be a tool used by, and I'll also fill in a few places where I did write down, okay, well, they said funding was the issue, so I'm going to write funding over there. And so that will be absolutely an item of discussion, a tool for the working groups, for them to think about how to enhance those recommendations, but also a way to report back to you all what those barriers are. So thank you.
Any further questions? Senator Fagg.
Dumb question number 2. Thank you, Madam Chairman.
No, there's no dumb questions. Stop it.
Well, when we look at mental health, to say where we, in the last 10 years, whatever, it's got worse, we've had more issues out there. Have we ever sat down and identified what caused it? I think a lot of this is what we're going to do about it. But to understand what caused it kind of helps that process. You know what I'm saying? It's kind of like you're putting medicine on a sore. Is there anything to understand what the sore is to kind of help the process? And I'm just sitting here with that thought.
Well, if I recall correctly, and some of the members that were on this last year, is during our discussions, I think you kind of hear that, because I think that's why the ad hoc members are so important, because these are the people out there in the field doing this, whether there are our law enforcement, our judicial people, our education folks, our specialists in our CMHCs and different folks, is they're bringing what is happening today. And so they can usually tell you what they're seeing as maybe being the issue that's driving something. We know that the number of mental health issues, as we heard earlier today on the 500 plus, we know that that was driven by COVID, for example. But is it living, is it an environment? Is it a culture? Is it, so all those get looked at. So, don't be afraid, even in those groups, is to ask those questions, because I learned mental health care is not my background in my private life whatsoever, but I just have a passion with it, and what I've learned and the knowledge I have is all these experts that I try to surround myself with, and if I don't have the answer, I know that I can contact one of them. And that's the thing, as you learn, who are those contacts that you can pick up that phone when a constituent calls you and says, well, this is happening in my area. And you're like, well, who do I call? Well, you can call one of us and we can tell you who to call, or you'll start working with some of those folks on this committee. And just because they're not in your area, they may be facing that in another area of the state. They have an answer, or they'll tell you who it is that you can visit with.
Yeah. Thank you.
You're welcome. Further comments, questions, anyone? How about online? Does everybody understand what we're doing and why we're doing it and how we're doing it? Boy, you are good, Carrie.
Well, and I've even got more details to go into in a little bit.
Okay, let's get going.
So I'll just keep digging. So, and actually, we will return and talk a little bit more about the process of each working group, but I did want to open it up and have a discussion about additional topics, either based on what you heard about today, you heard about it from the audit, what you heard from maybe during the legislative session, or anything that you heard even in the updates about existing recommendations that you think would be potential topics that you want to make sure the working groups look at, even if it's related to an existing recommendation, but you wanted them to really dig a little bit more deeply, or wanted to make sure they spend a little bit more time on. We'd love to be able to spend some time doing that right now. I will add, and I can send this, Senator Fagg as well, in the working groups last year, there was a kind of a streamlined, pretty quick SWOT analysis, the strengths, weaknesses, opportunities, and threats analysis that each working group did about these key topics. And so it's not exactly a cause and effect analysis like you were talking about, but it did help inform some of the recommendations. So we can provide the notes from those initial conversations, because that is the basis of the recommendations, but they weren't. You have to kind of go back to those original discussions sometimes to really get all of the background about why, what's this recommendation intended to fix, and not only what is it intended to improve an outcome on, which there's really pretty good discussion in the report about the rationale for the recommendations, but maybe goes back one step further and says, what's the underlying issue here that we think needs to be addressed, so we can make that available too.
Senator Hawk.
Thank you, Madam Chair. At the end of the session before we broke for lunch, we were talking about the K-12 mental health intervention pilot program. And I certainly would want to make sure that was a topic. Now, maybe it's number 4 under services and workforce, but since it wasn't broken out, if I understand, in the 2020 report. I
Mhm.
certainly would like to have it looked into and look at the possibilities of making a decision about it.
I know that the working groups had discussed it, but I think it was probably because it was a pilot in process. But what I'm hearing you say is the topic is probably a decision about sustainability and what does it mean, or expansion. Yeah, okay.
4 years is a long time for a pilot. Did you have something, Barbara? Senator McGinn.
And to add to that is, I think we need to have very good details about the funding of it and whose responsibility it will be. Will it be Department of Education folks? Will it be SGF? Will it be, what would be the funding source and how that would work? Thank you.
I can add right now, Senator, excuse me, I apologize, Senator McGinn, that the current funding source is the state is paying for some schools at 100%, some schools at 75% for the liaison. That's it. That's the SGF piece. All other funding sources come via Medicaid match dollars, because the CMHC can bill Medicaid, CHIP, and private pay insurance. So the only SGF, well, outside of the SGF match for Medicaid, the SGF for the liaison is straight SGF. And it's coming from the state, whereas in my opinion, I think it should come from the school districts, because it's a liaison per building, not per district, it's per building.
So
Senator McGinn.
when you talk about the Medicaid, is the extra money coming in? My next question would be, are we serving all children that don't qualify for Medicaid?
We have a small portion, and off the top of my head, I can't tell you how much that is. I want to say it's like 1.5, maybe $2 million for uninsured.
Well, I'm talking about, what about the kids that are insured? I mean, if we're talking about liaisons in the school, are we going to help all kids or the kids that are in a category?
Go ahead.
And if we're going to help all kids, we need to know what the financial responsibility would be and who that would fall on.
The pilot originally started with alpha and beta kids, with the alpha kids being foster care children and the beta kids being our high needs kids. And what it's evolved into in some of these schools that have been there from the day one, it's involving all kids. And they've also seen where kids have started coming to their teacher and saying, I don't know what's going on, but Bobby hasn't come out of the bathroom and he's sitting in there on the floor. Whereas before they may have ignored that, but they're kind of becoming a little bit more aware. The stigmatism's kind of coming off of mental health a little bit. So it can be any child. It's just that that's where we started the emphasis, because we knew that the issue we were having, we were shortchanging if we didn't get the right needs for the foster kids and the high needs kids, which can cost these school districts a whole lot of money. And so that's when I talk about, it's not really a cost savings. It's just that when you can do that Medicaid match, that's kind of where the savings comes from. So it's not 100% from the state or from the school district.
Okay, correct. But I need to understand, if you're talking about the high-risk kids, the Medicaid kids, the foster care kids, what about the average John Smith that lives down the road that isn't a foster care kid, that isn't a high-risk kid, but has mental health problems? If we have more and more of them, there's going to be an expense somewhere to handle the load. If we're going to help all kids.
Yes and no. The job of the liaison, and I wish the experts were here that are doing this. The job of the liaison in the building is to get feedback from teachers, counselors, anyone that's involved in the school of kids that they're identifying or they're seeing issues with. It doesn't have to be a child that's a foster care or a Medicaid recipient kid. It can be any child that they're seeing an issue with. Then that liaison lines them up with the CMHC. And the CMHCs are actually, assuming we can keep our staff, are actually coming into the school buildings to provide these services for these kids. So the kids don't have to travel. You don't have to worry about mom and dad having to get off work. And mom and dad does approve this. I mean, they have to sign off. We have all of that. Is mom and dad doesn't have to take off of work to get them to a session. It also means that the child has less time out of the classroom, which is an issue we were facing, because sometimes the child would have an hour appointment, but maybe it was 30 minutes to and 30 minutes from, so now you've missed 2 hours, and the parent says, oh, well, there's only another hour or 2 hours of school, so we'll just forget about it. Well, 4 hours missing in a day is a pretty big number, and these are kids that obviously really need to be in the schools. So you don't increase your expense on the liaison, and we actually reduce the expense on the liaison, because when we started, the school district said they should be master level social workers. As we progressed through this program, we realized they could be anyone, because they don't have to be clinical, anyone with a bachelor's degree to direct it. So we've even had some of the districts that have actually hired one of their teachers to be that liaison with the CMHCs, and the CMHCs come in. They also have meetings that are after school hours. So some of them are meeting till 6 or 7 o'clock at night in the school buildings.
So
maybe I'm not understanding your question, and I apologize.
So let me bring it back. Yesterday, you and I were at a meeting that had to do with Marathon Health, and one of the things that we talked about had to do with they have an increased load on people needing some mental health behavioral services.
Mm-hmm.
So we increased it by a 0.5 person to get them to an extra person. So there's an expense to that. And so what I'm saying, so if you have the CMHCs, and they have 10 kids last year, but they're going to have 20 kids next year, that's going to take more of their resources. So who pays for that extra help of those individuals that come to the school and help the child?
Well, that will come out of the CMHC's budget, but 9 times out of 10, they're billing Medicaid or private pay.
Yeah.
Does that help?
That
Because your
helps.
question's very valid. Your question's very valid. But that's why every time a school district hires one of our social workers out of our CMHCs, that puts them into a bind of not necessarily having enough people. It also means that a child only has services when they're at school. So if it's an in-service day, it's a holiday, it's a weekend, it's an evening, that child doesn't have access to that services. Mm-hmm. Whereas if you have the connection with the CMHCs, which most of them will become the CCBHCs, then you have that 24/7, 365 days a year.
Yeah.
I hope that was as clear as mud.
It was helpful, but I just want to make sure a lot of times we say we want stuff, but at the end of the day, when we leave here during session, we have to fund it as a legislative body. And sometimes we don't want to fund stuff.
Right.
We like to have the good talk about helping kids, but we have to fund it if we're going to do it. Thank you.
No, I think you have a very valid point, and it was something that we were very cognitive of as we were working through this process when we started designing this. And, we've learned a lot of things along the way. We were able to reduce the costs on what it is for the liaison. I think it's just something that school districts are going to have to decide whether they actually want the program and should the state continue with it. So that's what we'll discuss here. But the funding, as you noticed on some of those things you heard earlier, the obstacle to them not proceeding is because of funding. So yeah, these committees have been very well aware of that, and I've been appreciative of that. It doesn't mean they're not asking for more, because the providers are, but they also know that it's up to us. Is there further questions, comments? You're looking perplexed over there, Representative or Senator Erickson.
Thank you, Madam Chair. I need to work on my poker face.
I don't have one either.
Following the questions from Senator McGinn, as far as the funding and thinking about how schools in Kansas are shifting to more of a focus on social emotional learning. It's part of their accreditation. It's part of their 5 pillars for the educational foundation in Kansas. How does their funding relate to social emotional learning as they focus on that as one of their 5 core areas? how does the funding follow that? I mean, we very closely can follow funding for a number of math teachers, English teachers, so on and so forth. How do we look at educational funding around social emotional learning, and is it going to support programs like this? So that's what I was kind of pondering at that point. Thank you.
I would say the first part of your question is how is that funded would be, we'd have to ask from the Department of Education and have them talk to their schools and see how they're funding that, because that would not be a funding mechanism of the mental health K-12 program. And we might have staff at some point update us on what we're spending on that K-12 program now. Further questions or comments? Senator Hawk.
Thank you, Madam Chair. A couple of things, and I think they're probably in these topics, but I guess we're on additional topics. I'm concerned about the waiting lists, and I know this probably bleeds over into HCBS committee and other stuff, but on the behavioral health, how big a problem is that? And that sort of gets at Senator McGinn's question about how do we fund it. And I know some of those waiting lists are bigger in certain categories than others, and they're probably all higher than any of us want them to be. But does that fit in one of these categories? And then a subset, I always have to say two things at once. The subset that I maybe struggle with is autism considered part of behavioral health? I've seen it was mentioned in one of the reports, and that's an area I have a concern about in terms of waiting lists, and particularly the older autistic kids that may hang out on waiting lists for 7, 8, 9, 10 years before they get services after they become 21 or over. So anyway, I don't know where that fits, and maybe I have to wait for my other committee. If it fits, I want to make sure that we look at it somehow.
Well, I don't have an answer to that, but it doesn't mean that during the working groups, you wouldn't be able to bring it up. And then with the guidance between the ad hoc members that are on there and KHI, they kind of help kind of keep things on target, because it's really easy for all of us that are, worried about the social services of all the budgets we deal with, of getting sidetracked, and they keep us focused in that. So I would definitely bring that up in the working group. Carrie?
No water in there. And the lid was on too. A couple suggestions. I think absolutely. So I put this on the list of potential additional topics. There was a recommendation and a prioritized recommendation about addressing the IDD waiting list from this group last year. I think we heard a report on that earlier because of dual diagnosis, individuals with dual diagnosis. And then I would also add, I've mentioned my colleague is attending and facilitating the autism task team meeting now, and that group is made up of individuals, some of whom are overlap with some of the folks who are on the round table for this committee, as well as other folks who have a really special expertise in autism and in autism services, and the issue of the waiting to be assessed. Basically, the process on the autism waiver is also being discussed. One thing I could suggest either for the committee or for the working group that might be looking at that is getting a report or an update from that task team about what they're working on, because they're developing recommendations specific to that. And for youth particularly is why the group was convened, but as you said, it's they actually are looking over sort of the life course, not just youth.
Further questions, comments? I think our online crowd's being pretty quiet out there.
Right. This is the opportunity to say, hey, what did you not hear this morning that you'd want the working groups to at least look at and to figure out if it might make sense to either create a new recommendation or I'm very open, or I think although many of you will be on the working groups, I think you may not be on the one that's talking about an issue that you're interested in, that you want them to look at a previously made recommendation and maybe address one of the things you heard were identified as barriers. So really anything like that, so we can make sure that the working groups are loaded and ready to go when they first start meeting here in a couple weeks.
So for those of you that are online, this is an actual roundtable discussion. We're not setting in a format that many of you are familiar with, that we just take testimony, whoever's standing there at the mic talking. This is your opportunity to provide input and guide us as we go along. So are there any questions or comments?
Madam Chair, this is Sandra Berg with United.
Thank you, Sandra. Welcome.
Thank you. One thing that I did hear early this morning was the report from the audit and the lack of outcomes. And I know that was a concern, I think, that was brought up about accountability. And I know it overlays into several other topics, but I just want to make sure that we do visit that within our committees.
Excellent point. Further comments? New comments, new ideas? Representative Lynn.
Thank you, Madam Chair. I can't remember if this is something we addressed last year or not, but I'm wondering about special populations like veterans or rural communities, if we can have somebody like a stakeholder from one of those groups that can talk to us as well.
Good. Veterans and rural specifically, yeah. I know there was a discussion that you all had last year. Have to refer, there's enough recommendations. I'm trying to remember if there were any that were specifically prioritized.
I feel like we talked about it,
Yeah.
and I can't remember what happened from that, but thank you.
Senator McGinn.
Just to add to that, I can't find the article right now, but there was an article that, well, I think it came out from you guys, Kansas Health, about the increase of suicides in rural communities.
Yeah.
And escalating higher than the urban areas. And I think that it'd be important to understand what's going on.
Thank you. Yeah, that's one of the things that the working groups potentially could talk about is, are there lessons from either other states or programs that have been effective in Kansas? And are there, one of my colleagues who worked on that, who's from a small town in western Kansas like me, said it can sometimes policies, when you think about trying to make them, or interventions to trying to make them work for rural areas, we just think of city, they're just smaller cities or something. That's not rural Kansas. There's different considerations and different populations. So definitely add that to the list.
And just to add, and I know not everybody that lives in the rural area are farmers, but Land O'Lakes actually had a program, and I haven't checked up on it lately, but that they have a farmer hotline for people considering suicide. So I can't remember if Iowa's one, but anyway, I would check into that Land O'Lakes one.
Thank you.
Representative Featherston.
Thank you. I serve on the Ag Committee, so I went to the Governor's Conference on Agriculture. They had someone from Minnesota testify that they have 2 people on the ground out in the rural communities specifically funded by the state for mental health specifically to the rural people. And I had a good conversation with Representative Mosier about that. And I think they've had some conversation about how to move that forward. But she really emphasized that they don't want to call into a hotline. They don't want to call into Kansas City, Topeka. She's like, that's not helpful. We would like to see real people in real communities. So Minnesota had a really good model for what was going on. And I'm sure you can find the contact information, but if you can't, I did write it down. And then I did a phone a friend while we were talking about data and statistics. I have 2 friends that are counselors. I'm like, do you report your progress? Is there a place you report this to? And they both said, they don't take insurance, so they don't. It's not typical that they would report somewhere the progress. And of course, as we covered, progress is different. So they wondered if providers that did take insurance did file some kind of report. So that might be a place to find hard data on progress of those being treated. And the other comment they had is that trauma is not a diagnosis, but it's the foundation of so many things that if we could make real progress on preventing and treating trauma, we could cover many, many areas.
Further comments, questions? Representative Ballard.
Thank you, Madam Chair. You know, we've talked a lot, and I remember in our committee, we talked a lot about rural as well. But I think another area we have not really done a lot about would be people of color. And I think at some point we have to look at that because the suicidal rate is just as high among people of color when we talk about suicide, but also in terms of the role that poverty plays in this. When you don't have enough to eat, you're not sure you're going to be living in the same place, or you're living in shelters, or you may be in foster homes. So I think we will have to at some point look at what I would call the isolationist, whether it's the rural area, whether it's the people of color, and the poverty level. So I don't know how we address that, or, you know, I don't know if you go through NAACP, I don't know if you go through the churches, because that's where most, if you would look at it, among African Americans would be their churches, where their population, where they do it. But I think we have to look at that area because I believe that rate is very high. And lacking in counseling, the same as rural areas not being available, then the stigma is attached even more because you may be in the city, but everybody sees where you're going and what you're doing. So I think that's another area.
Thank you. Well, and you bring up an interesting point because it was one of the benefits that we discovered in the K-12 mental health program was in these small towns because the services are provided in the school building. And so sometimes the counseling may extend, because it's a true wraparound, and you and I have talked about wraparounds for years and years, to where they may find that it's some counseling that either needs to be done as a family or one of the adults in the home is needing some assistance. But now they get to come to the school building so people in their small town don't recognize that they're doing anything but going to their kids' school. So the stigmatism's real, whether we like it or not. It's going to be out there for a while.
And I will comment on that. When we talked about the Committee for Telemedicine, we talked about how safe would telemedicine be, because that would be another way they would get service, because in a small town, everybody knows, you know, where you go. I mean, you know, don't have to be real small. I'll use Lawrence, Kansas, 100,000 people, but everybody knows kind of like who said it, who, you know, where you live, you know, they'll tell you what you had on last week, you know, I mean, and you go through that. So you don't have to be real small for people to know if you're getting any kind of mental help. And so as a result, those people will not seek it, or they don't have the money, even on a sliding scale, to continue it. And I think that's the risk we run when we talk about mental health services being available, because they may be available, but people won't go because of that stigma attached.
Representative, I mean, one of the things that the working groups could consider is looking at, I think some of the recommendations or the discussion points that the Governor's Commission on Equity and Racial Justice, I think I mixed my acronyms up there, but have around behavioral health, because a lot of what you talked about at the beginning was related to this too, which is the rates of mental illness and behavioral health conditions are similar among all populations, but access to services varies and use of services varies significantly by race and ethnicity, and some of that could have to do with stigma, some of it has to do with socioeconomic reasons. So we could look at, that was a discussion item last year, but things that, an item that we can specifically ask the working groups to look at as well. And then I heard you also talking about social isolation and stigma, maybe even just more generally as well.
Well, I think, if I recall, there was some talk with what our law enforcement's dealing with, and I think now that we have the folks from the judicial side on this, is that, I hope we get a little bit deeper into that so we can get a better understanding and, what tools do we need to provide and how do we do that and what it might cost. Senator McGinn. I'm bad.
So I just want to comment on this sheet here, the one with the other colors. It does have the racial equity justice initial report. So they have some of the categories where they had input and some categories without input. So I would suggest that if somebody wanted to add to any of those or request that the governor's commission looks at some of those topics. I have a question because I was trying to thumb through here quickly back to what Representative Landwehr said about the local law enforcement. I was listening in on the Kansas Sentencing Commission last week, and Sheriff Easter came on and talked about a little bit of his frustration. He had an individual that was so, out of control, harmful, that it injured a couple of his police officers, and he had a hard time getting into Larned. I would like to know more about those situations. If there is a delay to get into our hospitals, if they are dangerous to our law enforcement, do we need to look outside the box and think about how else we can help our local jails who may not have the proper staff to contain some of these individuals that come through their system and get them the help they need. So I think in this situation, it was like they said we can't get them in for, 6 weeks or 6 months. Well, that doesn't do them any good. And so I just want to make sure we don't have, a clog in our system. And is that something that we can address?
Okay, did you want to respond to that, or?
I was maybe going to ask a clarifying question. Do you know if the individual was just being admitted for treatment or if it was an assessment? I know sometimes that can be a different issue for, because Larned is where they're being assessed for.
So I wouldn't know the proper term. I just know that they could not control the individual.
Okay.
And so it would probably was for an assessment.
Okay.
And again, and Larned was on the call as well, or somebody, I believe it was Larned. And they just said, we'll talk offline. And so I don't know how they worked it out, but it made me wonder, how often does this happen?
Okay, I have online right now, I've got Secretary Howard, and then I have Denise Seisman. So Secretary Howard. Secretary?
Thank you, Madam Chair. Sorry, I was trying to, my mute button wasn't cooperating. Thank you. Laura Howard, Secretary for DCF and KDADS. I had 2 comments. One goes back to the earlier conversation about veterans and rural areas. I think one of the recommendations I might have, I know that the committee received the reports from the Governor's Behavioral Services Planning Council this morning. There are, citizens from across the state that are on those targeted subcommittees. Some of those individuals might be good resources as we talk about bringing in someone to speak about rural issues or veterans issues. We also have some experience from some of our COVID-related relief work that we can also bring to bear on that. Also on the most recent discussion from Senator McGinn, I think one of the things that I think we'd certainly love to bring to the table in this group is some of the ongoing work that we have been doing within KDADS and with partners across the state towards having the ability to do more mobile competency, which would mean that individuals could be assessed in the community or at the jail, which would then mean that those beds at Larney would be freed up for the folks who need the most intensive services related to competency restoration. So again, I think that's a very, very important topic. We have a lot of work going on related to that right now. So I also would welcome that as a focus in the committee.
Denise?
Yes, thank you, Madam Chair. Denise Sisman from Community Care Network of Kansas. When we think about special populations, I wonder if we can also look at this, look at mental health for the various professionals and frontline staff providing services, particularly through COVID and the impact that has had. We're seeing, and I know that the hospitals are seeing the same, that many of our healthcare professionals are increasingly having mental health challenges themselves, either because they're working so much and they're pretty much exhausted, and or because they are also dealing with vicarious trauma, where they're dealing with helping individuals and families who are suffering severe trauma themselves. I think that this is not only an issue specifically to individuals who are healthcare providers and frontline staff, but also it does impact the overall workforce challenges that we have in healthcare in Kansas.
Well, and I know, Senator, again, you talked about with the law enforcement, and we can say the same things with our hospitals, in our ER rooms, with the assaults on personnel. And that was one of the things we heard the other day as well with the King Care Oversight Committee. So, absolutely. Well, I think it's a big deal because it comes back to the capacity that we do not have to deal with these individuals. And the discussion that we had, and Secretary Howard can feel free to jump in, is in the King Care Oversight the other day was the need to look for another location, at least one, for a regional hospital for our adults. And we have the 100 beds for youth now in Sedgwick County, but guess what? They're maxed at 100 beds. So that's where opening up, having some of those youth beds with Hayes and different folks is going to make a big difference. Senator McGinn.
Thank you. I just wanted to add, I appreciate you bringing that up. We met with Val Gleason from Newton Medical, the people that represent that area, and that is a big issue for our hospitals all across the state. So if we could tie that in somewhere, I think that would be a good conversation. Thank you.
Further comments? Representative Ballard?
Thank you, Madam Chair. Since we're talking about special populations, I can't remember, we didn't discuss a whole lot about seniors. And we do know when we say isolationist, depression, because whether it's health issues, being alone, you've lost a lot of your friends, and of course COVID played into it, but this was going on before that. How do we get to them? Yeah, we have the Older Americans Act, and we have, AAA, and we have all these other things, but what about, Meals on Wheels was serving a greater role than just taking food to their house. They got to see somebody every day. And, if you got to know them, it was a relationship. Now we find we have fewer people that are delivering Meals on Wheels. And a lot of those people did it for years, and now they're too old to go and do it. So how do we take care of these issues for them where depression sets in?
Sandra Berg?
Thank you, Madam
Sandra.
Chairman. The other population I was thinking about was the maternal health, and we heard a lot about that last week in the Oversight Committee, but I think maternal mental health is critical in getting help to the moms postpartum, getting them the support they need for their mental health as they raise their children.
Senator Fagg.
Thank you, Madam Chairman. Representative Lynn kind of kicked me on this thought here. when she said military. So I guess my question is, what's the state's responsibility in the field of mental health? Because I can name you three things. You know, military, to me, somehow the federal government needs to play a big active role in that, in my opinion. In-state versus out-of-state, we have a busload of people show up from either down south or from Afghanistan. They got a mental health problem. Some of them here that's illegal. You know, what responsibility do we have in that area? And then Department of Corrections, if you got a guy that's in there for life versus somebody that's going to go back into society, I don't know how much work goes into each one of those kind of people. And the money we're spending on that might be spent on the children if we was trying to be cost effective in what we're trying to do. So I don't know if that fits into a topic that we come into, or I think trying to understand exactly legally what we have to do to draw a line out there, a moral and a legal.
Further comments, questions? Senator Hawk. I was looking to see if I had anyone online. Go ahead, you're
Sorry,
good.
my last one, I hope.
No, don't say that.
Well, it's not a dumb comment, but it might be. I've had veterans who have lobbied me to see what I could do to get a veterans court, and I notice we have a judicial rep here. And I think there's been discussion about mental health court. A lot of things we incarcerate people for, and of course, I think what was the number, 50% of the people that are in our prisons have a mental health diagnosis also. So I just wonder under what category might we look at a way of maybe saving money and being more effective if there are some specific kinds of courts. And I've heard negatives about that also in terms of whether those are a good idea or not. But if we haven't looked at that in our previous recommendations, I think that's certainly a subtopic that we want to look at and see if there are ways of dealing with either specific veteran court or mental health court or some other variation of that that might be helpful.
And Judge, if you'd like to jump in on that, because I think we have some judicial districts that do have some of these different courts. I have not looked into what's good, bad, or indifferent, or what it costs. So give us your name, because the people online need to know who you are.
I'd be happy to do that. Thank you, Madam Chair. And I appreciate the opportunity to speak on that. I will tell you first when we look at these problem-solving courts, such as a Veterans Treatment Court, I will tell you that we started the first Veterans Treatment Court in Johnson County, and Judge McCarthy, who now is touring the state to assist other judges who may want to start a Veterans Treatment Court on how they started it. They did get up and running preliminarily with county support. We're able to then apply for and receive some grant funding. So from a funding perspective, they were able to receive outside funds to get the Veterans Treatment Court going. I will tell you that in the, I believe, 3 years, I don't know exactly, but the 3 years that our Veterans Treatment Court has been going, the one statistic that I will share with you, because it blows me away, is they have had 0 recidivism. Everyone that's graduated from the Veterans Treatment Court has not re-entered the system, and Judge McCarthy has done a great job with the veteran mentors and working on that. We have behavioral treatment courts in Kansas. Judge Picorni, who may or may not still be on, has a pre-sentencing behavioral treatment court in Douglas County, which I've visited, and it's an amazing program on the relationship that the entire team is building with someone who's in a pre-sentencing situation, somewhat like a mental health diversion. We also have post-sentencing behavioral treatment courts. Judge Russell runs one in Wyandotte County. I've been meeting with Tim DeWeese in Johnson County about potentially starting a global behavioral treatment court in our county. So we've got some established and some initiatives that are going on in the state. And the resources that are out there to at least get courts up and running on the education, the needs, the funding, the team, they do exist. We've invited one of them to speak at our summit, which I won't go into too much right now, but I will tell you that we have veterans treatment courts and behavioral treatment courts going on currently in the state. that appear to be, based on the data that I've seen, extremely successful.
So I think, Carrie, that could definitely be, now that we've got our judicial folks on there, what does something like that cost? How effective it is? And I think those folks would be able to tell us. Anyone else online or that I've missed? Representative Ballard.
Thank you, Madam Chair. May I ask the judge a question?
He doesn't have to answer you. Oh, wait a minute. No, this is our court.
Okay, good. I'm intrigued by what you said, especially about no recidivism or anything else, but who funds this?
Well, and again, and I wish Judge McCarthy was here, and actually, with permission of Madam Chair, when I'm done speaking, I might text Judge McCarthy and get clarification on this. But it's my understanding at the initiation of our Veterans Treatment Court, we were able to partner with our county to get it kind of up and running. And then once we had the parameters established, we were able to more accurately fill out more national and federal type of grant requests and say, this is what we've started. I'm almost positive we didn't get the funding and then started. We got it up and running for a few months and then requested some grant funding. I don't believe, and again, I will get clarification, hopefully provide it to you before we're done today. I don't believe we're receiving any more grant funding. I think that currently, based on the success of the program, it's now fully county funded, but I will get that information as we continue and report before we adjourn.
Thank you, and thank you, Madam Chair. But this is very interesting, and I'm glad Senator Hawk brought this up, because my understanding is sometimes when it involves a veteran, you may see it as domestic violence or abusive, but actually it's a mental issue, a mental health issue because of either what they suffered as being in the military before, and it can be late in presenting itself. And so if you had a kind of court that would know more about what those kinds of disorders might be, then you don't just lock them up, you have to treat them. And so it'll be interesting in terms of where the funding comes from and how do you find the people that have the expertise in order to be able to work with the veteran population.
And in addition to if I may respond, Madam Chair, in addition to the experts and finding the right resources, the Veterans Treatment Court that we run also has a veteran mentor for every person who's in. So we bring a veteran in who walks side by side with the person. And there's a criteria. I mean, it's a plan that's been developed with the district attorney's office, with the court, about who's eligible and who can get in, but it is designed not only for the professional resources, but just for that person who's been there, who's saying, I'm here for you, and that's been an extremely successful part of the program.
That's interesting. It's sort of a takeoff on Alcohol Anonymous in many ways. The person that has been through it can help you through it, or they'll understand or have empathy or whatever. Thank you so much.
Yeah.
And
I'll
I
get that
appreciate you
information.
answering the question.
Yeah, I'll get
Thank
that
you, Madam
now.
Chair.
Further comments, questions, discussion, ideas?
No, I have a
Now,
Madam
some of
Chair.
this will get rehashed as you go into your working groups, and you'll think of things as you proceed through that. So this isn't your only or last opportunity. Because the work that, as you've heard earlier, that come through last year was through the working groups. It wasn't necessarily in the full committee. We just get to decide if legislation moves forward and what goes in our report. Carrie?
Maybe it might be helpful to take a couple seconds to just think about the things, or a couple minutes maybe, that we've talked about and how those might sort out into our working groups, so that you all have an idea which working group will be working on these issues. And I know we haven't yet talked about any telehealth-related recommendations, and there's a specific or potential other areas or specific things in telehealth that you wanted that the special committee would like to direct the working group to look at. So I just plant that seed with you as well. I know that it's a broad topic with a pretty broad mandate for looking at recommendations, but if there's any guidance from the committee, that would be great. While you're thinking about that, or how do you want to proceed, Madam Chair?
Well, actually, I've got someone online with a question, and that would be Wes Cole. or comment, one or the other. He's got his hand raised. Wes?
Yep. This is Madam Chair. Can you hear me? Can you hear me?
Okay. Once you figure out how to get back in, or our staff is going to check on some things, we'll come back to Wes. So go right ahead, Carrie.
Okay, so I think what I heard, and I'm scribbled all over my page, so if I've left something out in this sorting, don't worry, we'll still have the opportunity to talk about that issue, but you can also remind me right now. I heard several discussions that were related to probably groups that we would call special populations, or we might sort it into a special populations area, which, if you'll recall now, is within the services and workforce group. I mean, maybe just based upon the kind of recommendations that we had, I could see that they potentially could belong in a different working group as well, but right now that's where they would be sorted out. And that included veterans, but kind of a thing to consider. The courts issue we talked about would be in a different working group. The legal system and law enforcement is within the realm of system capacity and transformation. So a question for the group is, do we want to think about veterans issues more broadly within sort of the populations area of that the first working group would look at, or do we want to think of that as primarily within the legal and law enforcement section because of the discussion around courts, although I know it wasn't just about veterans treatment courts, but about behavioral courts generally that we're planning to talk. So a question about that, because otherwise I think many of the other groups that we would, or the special population discussions we've had fit within that services and workforce group pretty well, but that's one where there might be some tension. We could still divide it up because there's separate issues. One, some of the issue is access to treatment, folks that have not had interaction with the legal system. And then there's the separate issue of the courts. So do you want to divide that issue, or do you want to try to keep that together?
Well, it's almost, Carrie, I think there's, it's kind of a twofold deal. I could see the veterans being with the services and workforce in some of our programs that we have out here, but then also whether it's the veterans or the behavioral or the substance abuse courts that we may or may not have available in our state and our judicial districts probably belongs over in the system capacity and transformation.
So maybe just depending upon the lens that the working group's looking at it. So both working groups can look at veterans issues, but maybe through a different lens. Okay,
I kind of think so, because I think that there's some programs that out there that wouldn't necessarily be court-related. So that would be where those would be under the services and workforce.
The other one that might have some crossover is Senator Hawk's question about autism and then probably the IDD waiting list as well. The way that was, I think, sort of before it was within funding, so it would sort of fit within the system capacity and transformation working group. If you are thinking of children with autism specifically, it might be within more of the services group. So again, it could be sort of a lens issue based on whether it's a funding system transformation issue or access to services. I tend to think I would probably sort it towards the system capacity, because it's almost by definition, it's about capacity. But that was another one that maybe could go in either bucket, but if you all are comfortable with that, probably lean towards the system capacity bucket for waiting list.
Senator Hawk, what do you think?
Autism.
I'm thinking autism and IDD waiting list under the funding and accessibility.
Yes.
And Sarah Fertig, are you still with us?
Yes, I am, Madam Chair.
Were you with the funding and accessibility working group last year?
I believe so. I know in every capacity, we spoke about the funding piece.
Okay. So, I mean, that's, so there's our Medicaid director that'll also be a part of this here. So we'll have the right people to ask the questions of and come back with solutions. Thank you, Sarah. Further comments, ideas?
Am I in?
Yeah, you can talk. Boy, this is a quiet group. Oh.
Well, I was just going to suggest to make sure that everybody's sort of on the same page about, unless you've got somebody else online, what we heard about impact on law enforcement and assessments and mobile competency which Secretary Howard talked about, would be in the System Capacity and Transformation Working Group. You can see that certainly as a law enforcement and legal system related topic, I think, but I'm open to other interpretations. Suicide prevention, there are existing recommendations, so it's sort out to I believe, primarily the the services and workforce area. There is the separate recommendation about 988 funding, specifically the funding source, and it could go in either working group. I think that's one that's still an issue, is sort of divided between two working groups because of the 988 funding source cries out for finance, but it could stay with the treatment.
And I believe that for the most part, the services and the idea of implementation is pretty much laid out in our bill. But it just comes down to the funding deal. So I think it would probably be good for this committee. And I know that Legislative Research has done a great job of tracking this for me off and on this last year of what other states have done on their 988 funding. Because when we originally started our bill, which was a recommendation from this committee, is we had two states. One had done like 15 or 20 cents, one had done nothing. They were funding it themselves, but they weren't the size or have the same issues that Kansas does. And then I think I heard some out there that are as high as $1. So it's all over the board. So I think it's probably, we'll have more information now on what other states have done for that to be looked at. So that hits on the funding side. Senator Hawk.
There's the other issue I brought up too, because the Attorney General has a fund, and I'm not sure if that was a grant, or it seems like that we put state general fund money into the suicide prevention work there. It really makes no sense to me that we've got two different agencies, even though they're working in different platforms on the same issue. But I think considering the people we have working on it and the fact that we have a cooperation going may not be a problem at startup, but I think it becomes a problem long-term if you're doing, I mean, it's possible that it gets a whole different emphasis between one agency and the other, and I think it needs to be integrated. So I would hope we might look at that. That might put it in the second category.
Well, and I think that, we could have the Attorney General explain, where that funding mechanism is and how much that is, and do they see it as integrating with that? I don't have a problem with that.
Maybe the best way to start may not be the best way to be.
Right.
Also heard, I think Sandra brought up outcomes data, making sure that we kind of keep that front of mind in the discussions and the working groups as we're developing or revising recommendations. There is also sort of the data issues or topic that already is as part of the system capacity and transformation working group. So that could be something we ask that working group particularly to weigh in on. A lot of the previous recommendations were related to interoperability and the ability of different data systems to speak to each other, so therefore different programs can as well. But you're also just talking about addressing some of the outcomes data that we discussed earlier. So I would suggest that, and that there was a related topic about claims. Representative Featherston, yes, about claims data potentially using that as a source. So that can be something we can ask that working group to look at, system transformation and capacity and transformation. Again, in the populations area, we heard discussion about older adults, people of color, veterans, rural communities, and healthcare workers, frontline healthcare staff. A lot of overlapping potential issues there that's within different populations, but we heard that particularly. And then stigma, I think probably within that area as well.
Well, and I think, Carrie, on this spreadsheet here is that we've got some things that are within that's come out of some of these other committees. That's what makes it so important for this committee to pick up all these other groups out here that are looking something that ties to this. And why we make it part of our report is to see what their recommendations are. Because most of the time, we find out that the left hand and the right hand are trying to do the same thing, but they're not communicating. And this is important for us to have that. So I think, we make sure that the working group members look at this here as well. I don't know that we have to go over this particular spreadsheet unless staff thinks there's something in there that is earth-shattering for us today. No. Okay.
You could, I think that's an excellent idea to both review that between now and the first working group meetings, but then also be a resource that KHI can help sort of bring forward recommendations from those organizations, from that, the crosswalk that KLRD put together that would relate to the topics that you all have identified. But if there's something else that you read later that strikes you that you didn't have an opportunity to talk about, there will be that opportunity in the working groups as well. It's going to be a little bit more condensed time frame for our working group this time around with the meetings, just with one fewer month basically that we're working on these recommendations, but with a smaller set of new recommendations or topics, there is the opportunity to bring additional.
Right. For those that are online, if you're wondering which spreadsheet I'm talking about, it is labeled Special Committee on Mental Health Modernization and Reform, September 2021, Recent Behavioral Health and Mental Health Committees and Task Forces Recommendation, KLRD Crosswalk. And then it talks about finance and sustainability, and it says workforce on the first sheet. All right, Carrie.
All right. That was just topics.
Well,
Madam Chair.
I knew that was going to be a heavy one.
No, that's
Madam
good.
Chair.
So now to talk a little bit about deliverables for the working groups. So I am not a builder, but I use Google Images to try to find a pretty good picture of a house that both had a foundation and had framing already completed. So to build on the metaphor of the report that this special committee, last year's iteration of the special committee and working groups developed, called it a strategic framework with the idea that continue to build on, maybe build additions sometimes, or maybe you're just putting up the siding or whatever we are to actually get recommendations implemented. So the 2021 as envisioned, the 2021 working group reports, which as you'll recall last year, the individual working group reports all got consolidated into one report from the working groups, will be really focused on those revisions and then additions. Knock on wood, we don't anticipate it will be as lengthy as last year's report, except for the fact that it will reference last year's report. It will basically wrap around last year's report. That 2020 report will be preserved as a foundation, and it will be the framework. So it honors the spirit of that living document that we hope for it to be, that you all hope for it to be. So we'll see. It depends on how many new recommendations we're working on. There may be many more pages than anticipated, but we do anticipate that primarily we'll just be talking about, hey, what's new this year after the discussions, and how do we continue to build upon. Oh, I think there's Wes.
Am I on?
Wes?
Yes.
Well, we heard somebody.
Can you hear me now,
just
Madam
talked?
Chair?
Oh, this is scary. What did you do, Carrie?
I channeled somebody's voice.
What'd you say, Ryder? Wes, you need to unmute.
Now can you hear me, Madam Chair?
Is he still muted? Okay, we'll come back to him.
All right.
Thank you, Carrie.
I can hear Wes on mine, and I'm online.
Okay, go ahead. Did you have a comment? Well, then
Problems
why did
here.
we just hear him?
Hopefully I have overcome that.
I think
wanted to
that's what they're
comment
working
a
on, isn't
couple
it? You sent an email. Yeah, we've sent that to computer services. Everyone online can hear Wes. We can't hear Wes.
Oh, wow.
Oh,
The world of technology. We're not ignoring you, Wes. We'll get you figured out. And if not, make sure you email us stuff and we'll make sure your
Okay,
voice is
all
heard.
right. I would sure like to talk a little bit about the veterans issue.
But otherwise, the
and,
report will look very similar. So it will look likely kind of like the, it wasn't called executive summary, but basically the overview of the report from last year. So we'll sort of have the wrapping around the rest of the report, and the 2020 report can be preserved perhaps as an appendix or something that can still continue to be the report. So don't worry, it's not going to be a big red line document or anything. We'll just describe any modifications or additions that are expected as a result of the conversation. So we mentioned this earlier. So as anticipated and in the scope handout we had previously, basically the working group charter, but also sort of the technical approach, there's a table at the back that includes proposed dates for working group meetings. We know that try to find some dates that were spaced well between special committee meetings as well, and didn't overlap with some other working groups or task forces that we know some of the roundtable members are part of. So if we need to work with the chair and find some alternate dates, we will. But in general, these are the times and dates that were proposed for the working groups. Meeting in a couple weeks, starting with all 3 working groups, and then telehealth working group meeting a couple times, because this group will have a slightly different initiation this year than it did last time. It needs to kind of start not completely from scratch. It has its previous recommendations, but it will have a slightly broader charge. The services and workforce working group and system capacity and transformation working group will begin with reviewing the charge and the checklist that we've all gone through. Many of you, most of the working group members will have already heard all that, so we won't spend a ton of time on it. I'll send that in advance, but they'll have an idea, be able to help complete the table that we shared with you all that identifies the enablers and barriers to the previous recommendations. Review the previous recommendations, and then potentially start to identify new recommendations that were based on the charge. So we may, depending upon the number that are assigned to each group, we may push some of that discussion also into our next meeting in the early part of November for each working group as well. We will, as we did last year, use survey instruments to help between meetings to be able to continue the conversation. If we don't complete the conversation or help us prepare for the conversation, we'll send y'all who are members of the working groups Qualtrics. I think we used Qualtrics last year, Qualtrics survey. It's a way to be able to collect information. It's not deliberating outside of the working groups because those are considered open meetings and will be broadcast on YouTube and the YouTube channel, everything as well for the working groups. But that way we can collect some information and then be prepared for the discussion with each of the working groups. The November meetings will be focused then on prioritizing the recommendations, again, likely supplemented with a survey prior to the meeting. And the special committee meetings in October and November, from the working group perspective, will be updates and sort of progress. And since most of you will already be on one or the other working group, it'll be able to hear what the other working group or other 2 working groups have been working on, as well as hear from other experts and whatever else you all may have on your agenda in those meetings. And then in December, early December, we'll have a nice rush to the finish line to get the recommendations complete, likely having the ratification meeting of the strategic framework just a few days before the meeting on December 10th. But I would anticipate, given the number of issues we're talking about, we'll probably use that date of December 2nd or some other date that works out for folks as well, to be able to complete any last work that we need to work on new recommendations. Oops, actually. Part of the work that we had talked about earlier for the working groups this time was to revisit recommendations, not to reprioritize from scratch, right? But to actually start to think about, hey, is there something else we can do to really elevate some current or revised recommendations to a legislature or agency, please do this next year sort of status, or maybe super immediate action, right? So a reminder of the criteria that had been used last year, and for new recommendations would be used. You don't have to dig through the whole rubric, but if it's in the back of the report, and those of you who are on working groups will remember this, this was the tool that was used by working groups to assess recommendations after the recommendations had been developed to determine sort of their level of prioritization. And Andy Brown, in his update from KDADS, used ease of implementation score, which was great, because now we'll be able to borrow that directly and put that under the table. But that also that flows from their experience, but also flows from this rubric. So there were, each of the working groups would consider each recommendation and think about implementation considerations. And I won't read all of them, but they had to do with thinking about, okay, is this a simple, I won't say simple, there's not very many simple changes. If so, they've probably already been made. But a change that can be done rather quickly with state control primarily, and there's not a huge funding barrier, et cetera, that would probably rate highly for ease of implementation. Things that might make it more difficult to implement would be, gosh, it's a whole new program, or there's a big cost, we need to figure out a funding source. The group was also asked about sustainability and basically trying to identify sustainability options. So, for example, the discussion about the 988 funding as a sustainable funding source, as well as what other mechanisms may be required to actually put this implementation into effect. So did it require a federal approval process? You heard a few times this morning in updates that the state is working with CMS on something that CMS has to approve. So that might complicate or at least lengthen the implementation. And then the groups also considered the impact, what kind of considerations there were about potential for high impact, and they would give that a score from 1 to 10. For those of you that weren't in those groups last year, it wasn't like you'd check one of these boxes and then somehow it adds up to a number. It really was these considerations were things that the working group kept in mind, and then they came up with a consensus score for ease and for high impact. And so one of the places where it focused on special population impact was in the prioritization of each recommendation. It also looked at serving those who have been disproportionately impacted by the issue. So one consideration for this was not just to count how many people it would impact, but basically the level of impact on those who were particularly affected. So you talked about crossover youth earlier. A relatively small population, but a highly impacted population, both on the youth themselves and then the systems they interact with. And then the potential for that recommendation to produce either savings or other good outcomes in some other area. Those were some of the criteria last year. And then the rubric actually was bigger than I could fit on one slide. The other questions that the working groups would ask themselves was sort of a relevancy test, and I think it was Secretary Howard who had suggested this last year, that really to each working group asks themselves, okay, how does this recommendation contribute to modernization? That's what this special committee is about, and so each of the working groups are working on that. So let's make that link to the real mission and the charter of the special committee. And then for each recommendation that did, there was an explanation or discussion, a rationale for how it did. But it's also just a kind of relevancy check for each group. Then, as noted earlier, the key collaborators and action leads were identified, and it's not on this matrix, but also measures for impact were also worked out. Typically, one of my colleagues, Hina, who will join us here shortly, would work on this with state agencies as well as members of the roundtable to try to identify potential measures for impact. And then the final question that the group would ask is sort of, okay, intensity of consensus. Is this something that one person cares a lot about, or is there intensity of consensus across the group for prioritization? And so that was another test for overall relevancy. And again, it was a group, all the working groups work by consensus. It's not like a voting mechanism where you're voted up or down. They try to get to the consensus on each of the recommendations and the level of priority. So a quick discussion perhaps, and maybe a little bit more abstract than our last discussion where we're talking about topics, is if you want, and open this up definitely for the roundtable members as well, if there are additional criteria or any kind of revisions to the criteria, again, not inviting a reopening of the prioritization work that had already been done, or the analysis that had been done on the recommendations before, not to like redo everything, but as each working group is looking at revisions and potentially saying, okay, what is the sort of the next thing we think needs to be done? Are there other criteria that should be kept in mind? And anything we could share or any ideas that you all would share, that could be something the working groups would incorporate into their work this year.
Comments, questions, discussion? I know that our computer staff is still working with Wes Cole to get him up. We think it's a bandwidth issue on his end.
I'll throw out an example, and you all can tell me it's not what you'd want us to look at, but or maybe it plants a seed as well. So a potential example could be something as simple as momentum. You know, there's something you heard about this morning that there's movement towards action on this existing recommendation or perhaps a new one, or maybe maybe we don't know what that momentum is yet, but that'll be the work of the working group to identify. Maybe that's a little bit too squishy of a criteria, but something like that about, hey, we think this has likelihood of being able to be approved and to move along through the system because it already has motion. It's already in motion. So that's the example.
Representative Carpenter.
Just to piggyback, like right now, you'd have to be living under a rock to not realize that we have workforce issues, you know, and I think that if there's anything that we can bring now to the table, it's the time. The time was actually a couple months ago or a year ago or two, but boy, whatever we can do to streamline that process. You know, one of the things that I think KSDE was talking about was re-implementing the CNA, temporary CNA license. And what was there? It had to have legislative approval to change a word or something on that. Something like that. But anyway, that's the kind of stuff that I think we need to bring to the table now, yesterday.
Well, I think we've heard that maybe that hospitals now, I think, were hiring LPNs, or maybe they hadn't, but that's a good discussion. Questions?
Can I try to interpret, maybe go take that, you built on mine, I'll build on yours. Perhaps, in not just thinking about workforce, because I think that was a really good example of something that, while there's momentum, but it also is there's something that was unique about perhaps the pandemic period or something that's been happening in 2020 that's created a new opportunity. I think you all talked about it earlier before with telehealth and some of the other updates you heard as well. Maybe that's even a criteria as well. Is there something that the specific window of time is right now sort of in the aftermath of executive orders and special CMS approval that was put in place because of COVID-19 that might open the door. That could be almost like a separate criteria, or at least a discussion item. Is the time maybe now for those kind of actions, because after a couple years we won't be in a public health emergency, and maybe some of those intermediate steps will have faded away. So okay.
I don't know if
that may be overinterpreting what you meant, but
I mean, I don't know. You could try again if you want. You want to try again?
Questions, comments? Wes Cole, do we have you back now?
Can you hear me?
Wes Cole, are you able to say anything? You are now unmuted. You're now unmuted. Don't hit your mute button, please. You are being able to be heard, I believe.
Now now do you hear me? Right?
Chair Landwehr, are you able to hear Wes Cole?
No, Robin.
Okay.
Could if people can hear him, could they interpret? Someone who can hear him, but we can hear? Just a suggestion.
Chair Landwehr, I understand he has a lot to say and would like to say it himself. Do you think we can
maybe
call
there's a
in?
way that we could, the ability of using maybe a phone?
Yep. Well, I've got a phone.
Okay, I believe Connor can unmute his laptop
Okay.
and maybe put a mic to that so we can hear it into the room. Let's try that.
All right.
Okay. Can you hear me now?
And you can only bend that mic down so far.
Can you hear me now? Can you hear me now?
Yes, we can.
You can.
Yes.
Okay. Madam Chair, and to the committee, I want to apologize for my little problem here with technology. Okay? I just wanted to comment on a couple of things that I've heard. And I think everything that I've heard is just wonderful, and the council certainly supports everything that's going on here and that you're doing. I want to comment on a couple of things. One of the things I heard earlier was about people who did not have insurance, and that is a concern. But remember, there's maybe even twice as many people that are underinsured, and that is a big issue also that we have to take into consideration. On the veterans and issues, I just want to point out on the Veterans Subcommittee report that we started here in the state of Kansas because we needed to look what the families needed and what the veterans needed. And we are looking into veterans courts right now. But one of the things that we did when we came out and we decided for the state of Kansas that we needed a directory and we needed some things done like CIT program, crisis intervention teams. They needed special training that was for veterans and veterans families. That was a problem with money. We have no money because no one on any of these subcommittees can be paid or anything. But what we did, we went to the American Legions and the VFWs, and we received money from them to get this type of training started across the state. And it's worked out really well. In fact, I think as we do our work and we look at what we need, I think we also need to identify those things that we can put in place with the organizations that we have within the state, that we can get those things started. I think once those things get started, I think that'll justify additional funding. Also, I want to point out to the group on the Children's Subcommittee, I heard a lot of discussion about children's issues. That report from this subcommittee is 32 pages long. Almost everything that we talked about today is contained within that report also. So I would like people to take a look at that report. I also want all of the committees to know that, and work groups, that once we get started, we have people here out in the field ready to work with or do whatever type of work that you would need done. Remember, with the With the council, over 60% of our members are family or consumers. So, that gives us a force right in the field that can work and assist our work groups in what we're doing. A prime example is like in the last group with the Rural and Frontier and Telehealth, we had Shauna Wright, who was chair of the Rural and Frontier Subcommittee, really get involved in that. She works with KU, and we did a lot of work, which was really good for us. Anyway, this council stands ready to assist in any way that it can with all of that membership, and I'm talking about several hundred people. So anyway, we're there, and if needed, and please look at these reports. And again, I apologize for not being able to get in earlier. Thank you, Madam Chair. Thank you.
Wes, I appreciate your comments, and I think if you don't mind, it would be helpful for us if perhaps you could list some of those bullet points.
Sure.
And send those to our staff here at Legislative Research.
Okay. Will do. Thank you.
All right, thank you, Wes, appreciate it. Because we got bits and pieces of it, but I think we kind of got the gist. So, but I want to make sure that we have your information provided to the committee. So thank you, Wes. Further comments, questions, topics, ideas?
Madam Chair, this is Sandra with United.
Sandra, go ahead.
One of the things I thought of as criteria in the rubric is the ease of measuring success. I know Carrie has on her slides measures of success, but I think if we're looking at each element, some are going to be easier than others, which will impact our ability to implement and measure that success.
Well, that's a good point. And maybe what we need to do is when we're looking at the rubric is this measurable? Mm-hmm. Or is it not measurable? Or is it something that we need to find those measures? Does that make sense, Carrie?
Right. I think as I understand the point, and both yours and Sandra's point, so not just saying whether it's measurable, but how hard it is to measure. And,
right.
I think the word that cut out, but I think you were saying ease of measurement. Sandra?
Right. Yeah, the ease of measurement or the accessibility of the information.
Yes.
Because I think there's something, Sandra, that we heard earlier from someone, and I don't recall who off the top of my head, so I apologize, but there's limitations that we get into on certain information and measurements because of HIPAA that plays a part into some of the things that we do. So it's something for us to definitely be aware of.
And one of...
Is that you? Okay, we expect treats at our next committee, just so you know that.
This was somebody who wanted to contribute.
Oh, to your campaign?
Yeah.
Well, thank you. And I think this is helpful. I know this is a little bit more abstract conversation to have about criteria rather than about the topics themselves. And there are so many criteria that you all had devised last year, but I think this is really helpful. One of the things that I think my colleague Hina's wrapped up with the Autism Task Team, so she'll be joining us pretty shortly to actually talk about the measurements of success. And so I may skip over that item and then come back to that very shortly when she joins us. But at a high level, I'll say that, and maybe this is reacting to Sandra's comment too, there's some data that if you're looking to measure at the individual level versus you're looking to measure at the program level or at the state level, there certainly is, and I remember we shared it with the committee last year, there's significant statewide data that's available related to SAMHSA data for behavioral health prevalence and incidence and other factors related to mental health services, or not, excuse me, not services, but outcomes, as well as services, but they may not be only for a specific population. It really is for an entire, statewide survey-based kind of data source. And then the more maybe difficult data would be individual level data, particularly if there's not claims data. So if it's outside of the Medicaid program, for example, or outside of data that's easily accessible. But that's something that each working group can keep in mind.
All right, other questions or comments for Carrie? Did you have, you've got another slide, okay.
No, I have more.
Well, keep going. I don't want to cut you
No,
off.
that's okay. Well, and it depends on where, I was going to, again, skip over measurements of success until Hina joins, and then actually just get to talking about participation in working groups. And you all don't have to sign up, don't have to write in blood today or anything like that, which working group you want to be on, but it'll be helpful for our communication if you know right now which working group that you would like to be part of. You can share that with us, or on the very last slide, there's an email address for me and for Hina and for Melissa also from KLRD, so that we'll all be on the same page about what working group everyone is on. Just a reminder, if you go back to slide, oops. This is 5? Yeah, 5. Has sort of the breakdown by topics, and hopefully kept a mental note about some of the other topics we talked about today, where we intend to categorize those among the working groups. But again, it's services and workforce. We'll be looking at workforce, community engagement, prevention, education, treatment and recovery, special populations, including a number of issues we talked about today. While system capacity and transformation, we'll be looking at funding and accessibility, data systems, legal system and law enforcement. We talked about a number of those potential topics today, and system transformation. And telehealth, we'll be talking about telehealth. So if you have an inclination, we'd love to either get that from you after the meeting, or however you'd like to proceed, Madam Chair, on dividing up folks for working groups. And that includes people that are on the roundtable as well. Certainly those are the members that want to encourage to participate.
What would be the easiest for our staff? Just have folks email you, Melissa and Carrie, or what would you like to do?
I'm fine with that. And then if you have questions, or if you're like, oh, I forgot where exactly this issue was that I really want to talk about, then you can follow up at this email address as well. Do note that the meetings are scheduled here in just a couple weeks. So the 13th and 14th of October are intended to be the first meetings. So if you're able to, even this week, to be able to let us know what your preference is, that would be helpful, so we make sure we can get WebEx meetings on your calendars.
It would be good to have that preferably by Thursday, but I think Friday should be our cutoff to just email them and let them know which committee that you want to be on. And perhaps what we could do is take the notes that we've all taken on your topic sheet that we added. Mm-hmm. And I know that staff's very good about doing it. They probably got more than I have here. Is add those, and then let's send them out to the members so they can take and look at that again. And it doesn't mean that we just try to get an equal distribution between these working groups. It doesn't mean that you can't listen in on any of the other working groups. We had members that actually did that last year. Some of them weren't even participants, but they were interested in the topics, and then they were able to provide us input from the outside as well. As far as legislators, I didn't attend every one of the working groups, but I tried to pop in on different ones of the working groups so that I had some idea of where they were going, what they were doing. And it was very helpful for me from a chair perspective, so that I knew how to proceed with the potential legislation that we actually put out and directions. I think that Representative Carpenter found it helpful. I think you have a comment, Representative Carpenter?
I do. Thank you, Madam Chair. And could you kind of list the topics underneath in smaller, funding and accessibility, for instance? I can vaguely remember what that was about. It's more than the top two, you know what I'm saying? The other things, that way systems transformation,
Right.
exactly. More of the bullets underneath that in a, without going through your whole sheet, you know what I'm saying, just to.
I wondered if it would be helpful, so this is sorted by, of the previous topics, the previous recommendations. It is sorted that way, but we can just use, if those little handles at the front are helpful, we could just list those on that. So you wouldn't have to read through the whole thing. You could at least just say, oh, what was workforce? Well, oh, that included provider MAT training and access to psychiatry service. Okay, yeah, we could do that. Yeah, a little faster.
Well, it becomes helpful, Carrie, especially for legislators that have multiple committees that they're trying to bounce back and forth for. So I know we're putting more burden on our staff, but it's greatly appreciated. I can guarantee you that. Comments? You do not have a good poker face, I'm just telling you. I bet the judge knows about poker faces in his courtroom, so. Comments, questions, anyone? Did you have a comment, Judge?
Yeah, not about poker faces, but I did want to let you know I did receive a response from Judge McCarthy. So to answer your question, he said, and I was wrong on the first part, they actually started with no funding. Judge McCarthy got together with the district attorney's office. They started getting it going. Then they got a 3-year federal grant. And then because of the success of the program, the county has agreed to, after the 3 years is up, to fund the Veterans Treatment Court Administrator position. So the county will be funding that position. They've also established a 501c3 that is helping directly veterans support as far as financial benefits when available. And then lastly, all of their benefits run through the VA. So they work with the VA as far as services go. To the extent that services are not available or something doesn't work out, then Johnson County Mental Health has paired with the Veterans Treatment Court to try to resource or connect. So that's kind of the resource and funding progression, the response I got from Judge McCarthy. So I want to share that.
That's very helpful. Did you have a comment, Senator? Okay. Representative Ballard, and then we'll come back to Senator.
Thank you, Madam Chair. Just to follow up, so they're working with the veterans, but are they contributing funding to this? Or is it just the county?
Who's the they?
You mean the veterans?
The veterans, yes.
No. It's my understanding that the actual veteran who is accepted into the program, who will become a graduate, is not paying anything. That's my understanding.
But our Veterans Administration.
The Veterans Association is what you're asking for.
Yes, like.
Oh, correct. Yeah. I mean, our Veterans Treatment Court Administrator will work with them as far as the contact at the VA, but for the actual payment for services would come from the VA.
Okay.
Is my understanding.
Okay, that's what I want to know. Thank you very much. Appreciate your checking.
Yeah.
Thank you, Madam Chair.
Senator Fagg. Thank you,
Madam
Judge.
Chair, one thing caught my ear, you said 501c3. If the local American Legions and stuff knew about that, they're always looking for programs to get behind and put money to. So
I'll pass that along to Judge McCarthy. And I know it's not just big issues such as maybe rent assistance or something like that, but even smaller issues. I mean, they have $10 Sonic gift cards. I mean, they have things that they go, and if they've met all their checklists, they'll go and get to grab something out of the bowl. I mean, there's lots of small incentives like that as well as larger incentives.
Further comments? So in other words, be looking at the work groups and deciding what work groups that you want to be on. And it's also possible that you get on a work group and you realize it wasn't what you thought, and you can make that switch. But I just found it very helpful from my perspective as a legislator. But we had a lot of legislators that picked a group, and that's kind of the group that they stayed with. And but that's up to you, because like I said, you're not reimbursed for the working groups.
Madam Chair, I think Hina has joined us.
Hina, are you with us?
Yes, good afternoon. Good afternoon.
Wait a minute, we're going to, hold on, Hina. We got to up your volume, hon.
Okay. And let me know if I need to throw a headset on. I can definitely project a little louder if needed.
No, it has something to do with the volume in here. We dealt with this the other day with the Can Care Oversight Committee, so you're fine now.
And Hina, you can just tell me when to advance slides, but we just saved the measurement of success section just for you. As you might imagine, we've had a number of questions and good discussion about data and how the working groups thought about measuring outcomes last year. So I think it'll be very timely. And otherwise, we're pretty much through our working groups discussion, so you get to back cleanup here.
Great. Well, I will try to be succinct then in my remarks if you've already been talking about the data. Just for background, for those that weren't part of the special committee or work groups last year, the special committee last year really discussed the value of using data, right? And they wanted to ensure that it was a component of the strategic framework. That's why in all of the recommendations, you will see that there are some outcome measures for those. So if you want to advance, Carrie, to an example, you know, if we use the example of a workforce recommendation 1.3, and this was around providing medication-assisted treatment training, you know, some of the impact measures here were number of providers who have completed MAP prescriber training, number of caseload carriers who have completed MAP prescriber training, and then number of age-adjusted non-fatal drug overdose emergency department admissions per 100,000 population. If the committee wants, this data is available. And Kelsey and KDHE, I don't know if you guys are on now, but they are able to give you these data points. So as this committee continues to work through this report, if there are some outcome measures that you would like data on, we can request this from the agencies and provide this in the 2021 report. So that's one thing I wanted to keep in mind. Do you want to advance to the next slide, Carrie? And then the other area that we can think through the work group structure is, here's another recommendation, 2.1 for certified community behavioral health clinic model. So in the 2020 report, the outcome measure there was number of CCBHCs. But with some being implemented this year, we could add new outcome measures to these recommendations. And so if you advance to the next slide, these are some quality measures that SAMHSA has for the CCBHCs. And so these can be incorporated into the report. And so as the committee and maybe the legislature thinks through the 2021 report and what they want to see data related, these outcome measures could be added to the report. So those were two things just kind of to keep in mind as the work groups are going through and looking at the recommendations again and revisiting them and refining them. We can continue to add that element of outcome measures. And just for those that weren't part of the discussions last year, the outcome measures were developed by kind of this little subgroup with agency staff from KDADS, KDHE, KDOC, DCF, KSDE, and the Kansas Attorney General's office. So it was pretty collaborative across agencies. And then what Carrie has brought up now is a data profile. And I don't know if you guys have the work group report in front of you or not, but I want to say it was like on page 44 in KLRD. You can correct me if I'm wrong, but there's figure 3, which is like this systemic view of 10,000 foot view of kind of a systemic assessment or a snapshot of the state's behavioral health system. And so as we're working through the process, I know this morning you guys heard about the number of recommendations implemented and you know how key collaborators worked through this process. But we also have kind of select measures that we identified last year and had in that report that gives you that 10,000 foot view of what does it look like. And so many of these can be updated with new data if the committee would like. I've reached out to KDHE, KDADS, and a few others about it. Some new data is available. Some data is not if a survey hasn't been sent out again. For example, the percent of high school students who report feeling sad and hopeless almost every day or 2 weeks or more in a row. This measure is from the Youth Risk Behavior Survey, which will be fielded this year, so data will be available next year. However, there are other measures like the mental health professional shortage areas, and a few others that can be updated if the committee chooses to continue updating this figure so that you can track what data is available and the latest available data is made available. So that's kind of all I have. I just wanted to make sure everyone knew that there are some measures of success built into this strategic framework. And as the committee would desire, we could have outcome measures and data available for the 2021 report as an update.
And Hina, you're correct. If you print out the entire report, the entire strategic framework, the discussion of the data profile starts on page 43, but the data elements themselves are on pages 44 and 45. And then within each recommendation, within the table for each recommendation, the measuring impact is like the second to the bottom box in every individual recommendation as well. But the systemic or system-wide one is on those pages 43 through 45.
Representative Ballard.
I'm sorry, I'm just following up. I'm looking at the last one with broader measures, mental health in America rankings. Can you talk a little bit about that, please?
Sure. So those rankings, I think they're going to come out at about the end of October, I would like to say. But the Mental Health in America rankings in general uses national data from surveys like the National Survey on Drug Use and Health, also the Behavioral Risk Factor Surveillance System through the BRFIS. And they provide this, they provide this kind of overall ranking that's comprised of 15 measures. So for adults and youth around mental health issues, substance use issues, access to insurance, access to adequate insurance, as well as access to and barriers to accessing mental health care. So they will have the 2022 ranking available. I'm hoping at the end of October. Sometimes it can be sporadic, and with the pandemic underlying, I'm not sure when the data will be released, but fingers crossed it'll be ready for the 2021 report. Does that answer your question?
Yes, it does, and that's very helpful because I think with all the different topics, if we look at all three, I think a lot of it comes down to maybe us looking at the rankings in the state of Kansas. That's how I think we can look at urban, we can look at rural, and we can also look at however they rank it for us to be able to get some of the answers that we were just talking about. Thank you very much. Thank you, Madam Chair.
And Hina, you might want to add too, I know we had some questions or discussion. I don't recall if it was in the special committee last year or in after some of the presentations of the special committee report to you all and in individual committees about the Mental Health in America rankings, because there's time lag with some of these, so it's always important to keep that in mind. And some of the measures that are used use multiple years of data, sort of average over time. So that's important to keep in mind. And we have a short memo, and Hina, I'm just not remembering if it was for the special committee or for another committee, that we could also share with the committee again, just as a reminder.
It was sent to the special committee, I want to say around January 14th last year, but I can ask KSDE to recirculate that. And it was also provided to some legislative committees that had requested it.
Representative Carpenter.
Wasn't that the one that we dropped significantly last year because of some measurement changes? I think it was. We were trying to figure out what that was.
Exactly.
Further comments, questions for Hina? Proceed.
Well, I think you're done with me for the afternoon.
We're never
that's
done
all.
with you.
So again, KHI looks forward to being able to spend time with folks here in this room and online. All of our meetings, the working group meetings, will be virtual, so you'll be able to join those from your homes or your offices or wherever you're calling in from. So we will have some flexibility there as well. And as the chair mentioned, they will be 90 minutes, and we try very hard to stay right on time, which means starting on time and ending on time. So look forward to having those conversations, and we'll work with KSDE on getting you a good description of each of the working groups so you know which one you're signing up for. Thank you very much.
Thank you very much. And I can't say enough about how valuable KHI has been in this process, and I was telling the speaker the other day, and actually Minority Leader Sawyer, that we need to look at maybe a new model of how we structure some of our task force. I think it could be more effective if we had, looked at this, maybe this blueprint and see how that would take and work, especially when you're on topics that are very complicated, very in-depth, and you can't, eat the whole thing in one meal. You've got to take it in bites and take the successes where we can get them. And I think what these measurements of telling us that, well, this is very complicated, oh, this is an easy one, it's the low-hanging fruit, not going to cost us money, let's get it done and implement. So I thank you and Hina's work a lot for what you've done and what you're going to do, so I appreciate that. Staff, one of the things I was thinking about as I was looking at the financial spreadsheet that you provided us, Matthew, is if we could add on here, and I know it gets tough, it might have to go to 2 sheets, just FYI. If we could add the funding source by state agency and the funding source, SGF, Fed, other, all funds. And if you can take it and play with it and see what the most simplistic way is to provide that. I think that would be an asset for us. Yeah, by state agency, because for those of us that don't sit on that budget committee, it'd be good for us to kind of learn where that comes from. Matthew, you have a comment?
I'd just like to clarify to make sure. So, for example, if we're looking at, the bulk of it is KDAD, so with like the community mental health centers, you would like that broken up to say maybe for state aid, how much of that is SGF versus how much is another source, when we get down to the other state agencies. For, this KDOC item, how much of that is state SGF versus how much of that's a different funding source.
You're right. And then we know where our all funds are at. Checking to make sure it wasn't somebody online. Rita, Connor, or Melissa, am I missing something that for housekeeping purposes? Melissa.
Madam Chair, I believe there was a motion that was requested to spell out the scope of the work that KHI was doing to make it clear the relationship that this committee will have with KHI since this is a new special committee.
Okay, and I believe that you emailed that. Here it is. Okay, it's a simple motion. It's just about being technical and creating the relationship between the legislature and KHI. And so the letter that I sent to the LCC asking for the formation of this is what we've sent them. So the motion is the special committee requests the Kansas Health Institute serve as the facilitator for the 3 designated work groups for the 2021 interim, and that would be my motion. Is there a second? Seconded by Representative Ballard. Questions or comments, committee members? All right. Seeing none, all those in favor, this is just for legislators, by the way, folks. All those in favor signify by saying aye. Opposed, no. Ayes appears to have it. Ayes do have it. Motion carries. Is there any other unfinished business? Yes, Melissa.
Madam Chair, this is just a reminder for everyone who's listening to the meeting. As Carrie mentioned, those working group meetings will be treated as public meetings. And so the public is able to access those. Information on the individual working groups will be published both on the KLRD website under interim committee meeting schedule and on the legislature's website on that 3-week rolling calendar that includes all of the meetings of the legislature. So members will be able to get it through either the Slick Harmony link or any member of the public or through the YouTube channel. So they will be able to hear that, and those meetings will be associated with this special committee, so they could get back to the special committee's work and the information that was discussed today, so they have that context as well.
All right.
When you send in your notice, if you have an email address other than your State House account that you'd like to be notified from for any working group lists, let us know. And if you do anticipate needing a substitute member, and this is mostly for our ad hoc members, please let us know in a timely manner, because you have to be admitted to the meeting room. So we want to make sure that you have the credentials, so that our host can make sure that our host is through the Legislative Office of Information Services. So they just need to know who's participating in the meeting that day, so we can get started and you can use your full 90 minutes for your meeting discussion.
All right. Are there any questions or comments on that? Okay, I'll just reiterate that we need our ad hoc members and our legislators to decide what working group you would like to participate in, and get that to KLRD. The preference is to have that by Thursday, if not, at least by Friday. I will add, and it's kind of the big elephant in the room, I've had a lot of people question what's going on with the telehealth. Because if this committee recalls that we did introduce legislation last year, the bill got halted in committee because of the discussion of rate parity. So I am assuming, and I'm always afraid to do that because it makes an ass of you and me, is that will be part of the discussion in that. Are there any further questions or comments? Representative Ballard.
Thank you, Madam clarification. So we already notified them, but I think last time they sent us an email before, which one did you want? And we responded back to that, so back to that email. But you're saying we should just send it into KLRD, our topic.
Yes. Is that what staff prefers?
If you will send it to myself and Carrie, that way Carrie Bruffett with KHI, that's very helpful. We are receiving several, so thank you very much. So we're starting to put together the list quite well. So thank you. Yes, that will be very helpful. And when we do send out that information, if you haven't already sent something and we send out the topics list, you're welcome to reply to that also, and we'll make sure you're counted. We'll follow up if we haven't heard from you Friday morning.
I bet you will. Thank you, Madam Chair.
You don't want them to come looking for you. I'm just telling you.
It's like my mother used to say, you don't want me to come down here.
Nope, nope. You get the look, and we all remember, I don't care how old we are, we know what that look is.
Yeah.
From Mama. Senator Erickson.
Thank you, Madam Chair, and I apologize if this was addressed, but seems to me like some of the working groups may be a little more popular than others. So how are we going to distribute members amongst, so we make sure that we have someone on all 4 of those working groups, because I'm happy to serve wherever there might be a need.
Carrie? Last year, I think it was magical. It just kind of worked. We were surprised, because that was, no, and Senator, you asked a very valid question, because that was a concern that we had last year. Carrie?
Yes, very good question, Senator. And I think as we get folks signing up, if we see that there's just an imbalance, I think we can reach out to the group or individuals in the group based on their maybe their participation last year. I don't know if everyone will sign up for the same sort of topic areas that who are carryover members. But if they do, there should be fairly even distribution. And then, of course, we've got new folks who may have new interests as well. So I think at this point, we can just see how it goes on Thursday. And if we've got one working group that has like 2 members, we'll be reaching out to you, recruiting.
We'll be asking you to either join another group or to choose another group. So. Go ahead. Oh, Rita.
Thank you. Just for clarification, emails regarding the working group are going to come from Melissa, not from me. So look for those from her. You'll receive emails regarding the committee itself from me. Any WebEx information is going to be sent to members through Kay Lois, and Robin will be sending those out. So look for Robin's name on those emails. I know there's some confusion as to where to find that. Additionally, Hina just provided me a copy of the Mental Health America report that was provided last year, and I will forward that to members, and we will see about putting that up on our resource page. And for quick access to last year's report, there is a link on the resource page for this committee on the KLRD website, so you can get to that quickly.
All right, thank you. Committee questions or comments? Wondering what we're doing, what we've done, what we've decided? If you think of some later, call Representative Ballard. She'll explain them. No, if you can't get hold of staff, you can feel free to check in with me. I do monitor my state email account, so to the best of my ability. I was telling someone the other day, I said it gets kind of tough when you're doing 3 email accounts and you're getting 100 average on each one of those today. So balls do get dropped, but don't feel like you're being ignored because we want to stay on top of this. You've been real quiet over there, Representative Smith. He's always like that.
He's been alert, though. You see that
We
look
just
on his
don't
face?
know. We just don't know about him. Anyone else? Senator Hawk.
So there is mental health parity, right? So can we get points on our state health insurance plan for serving on this committee? I need about 10 to get the $480 deduction. Just wanted to add another thing to your to-do list.
You know, perhaps if you had asked that earlier when Senator McGinn was here, because Senator McGinn and I are now on the HCC, and it's complicated.
No, if Senator McGinn was here, she would have given me a quick no, so thank you.
All right, you're welcome.
I hear you, Senator Hawk.
Thank you, Senator. No, she had to get to something else, but she said she would be monitoring, so she is definitely true with her word.
Too.
Yes, she was.
Okay, I know 10 points. Could I have 5?
Representative Arnberger, did you have a question or comment? Okay. Anyone else? Again, I want to reiterate, I thank every legislator that is on this committee for the work that they are going to do. It's not easy, it's complicated, but I can guarantee it's really rewarding. I couldn't have been more pleased with the report that we came out with last year, and I can't thank the ad hoc members enough for taking the time out of their day to spend with us on a full day of a committee hearing with us. And we're going to, like I said, we're going to try to limit how much we have to do all day. The bulk of the work is in the working groups for the 90 minutes that you'll be called upon, and you can do that everywhere but from your bathroom. We've not us, but there's been Zoom meetings that, no, they shouldn't have been where they were at to actually participate with us. So thank you very much. Did you have a comment, Judge?
Well, I was just going to ask.
See, you don't have a poker face either.
I don't. Madam Chair, and you always get nervous about asking to speak right before adjournment, but I was just wondering, since we are ending a little earlier than the agenda, if you wanted me just to take 2 minutes to talk about the summit for this committee in case anyone was interested in watching Thursday or potentially coming to it in April.
Actually, I think that would be a good idea. The judges is heading up for the judicial folks, and it's a committee that I'm on. There's another legislator. Senator Petty is also on that, and we've got some judges, and it was a summit that was supposed to be here in Topeka this Thursday and Friday, but because of COVID, it's gotten moved. So the judge is spearheading that, and I'll let him give his talk on that. It was going to be very exciting, and we're going to hopefully pique your interest for next April.
And I will try to be brief, and thank you, Madam Chair. We were scheduled to have a day and a half summit this Thursday and Friday. We elected to postpone that. What we are doing Thursday morning, if you're interested in, is because everybody that was coming, and we had over 300 people registered across the state. We knew everyone had Thursday morning at 9 o'clock open on their calendar. So We reserved it for a 1-hour Zoom meeting, and we have various members of mental health or behavioral health committees across Kansas, including Representative Landwehr, speaking very briefly Thursday morning, including Governor Kelly, Speaker Reichman, and Chief Justice Lukert, who are going to be speaking briefly about this summit, about what's going on in the world of behavioral health. And the purpose of Thursday morning is really to continue the momentum that we had built up for the in-person summit. We are going to do it in April of 2022. If you're interested, I don't know that I have all of your contact information, but I can get to Representative Landwehr the link for Thursday morning if you want to watch it. It's going to be very brief, 1 hour with some updates. And in addition to our local speakers, we had national speakers coming in. We received a grant to be able to put this summit on. It was a no-cost summit. I'd love to talk about it with you individually, more detail, but if I had to give you a summary, this is a national initiative from 4 different organizations, and the idea is to not just educate, but equip each county in Kansas through the judicial districts as it relates to resources that are available, programs that are going on across the state, and the connections to be able to talk about what that looks like. Very similar to the discussion that we had today about Veterans Treatment Court, Behavioral Treatment Court. Do you have a co-responder program? And we really brought together our speaker list of across the state, rural, large municipalities, and our attendees were not just judges and legislators. Our attendees were co-responders, law enforcement, mental health, government officials. We really had a cross-section of who was going to be attending our summit. We are going to do the summit, and if you'd like to watch a preview of it, I'd be happy to work with Representative Landwehr to get you the link to watch Thursday morning, just as a kind of a coming soon theatrical trailer to the summit. So thank you, Madam Chair.
Why don't we do this, Judge? Why don't we have you, have Rita get your email, then you get it to her.
Sure.
And then she gets it to all of us here, and, because I'm already got Representative Ballard in my ear, I want it. And then she'll make sure even some of our ad hoc members out there will get it, and then they can disperse it to anyone else that they want to as well.
Absolutely. I'll send that today. Thank you, Madam Chair.
All right. Thank you, Judge. Is there any other unfinished business that I need to address before I adjourn us? Did you have any comments?
I'm good.
Okay.
This is very nice.
All right. Again, thank you. I'm looking forward to having as much success as we did last year with this report, but it's not as low-hanging fruit as we had last year, even though I do have to say that the CCBHC wasn't as heavy lifting as it could have been, because it was definitely a bipartisan effort. We will have the ability to introduce legislation if that's the decision made at the end of this. If we've got recommendations, keep in mind the 988 piece. If there's things that you see in there that should be tweaked or changed as we move forward, we're interested in looking at that. So with that, committee, we're adjourned.